Good morning, esteemed colleagues and distinguished guests. Welcome to day 2 of ABSI SKILLCON 2026. Yesterday, we witnessed the guest lecture, keynote address, and amazing panel discussion with the amazing Dance on Culture evening program. Today, we are privileged to have a detailed video demonstrations curated by our experts. This video will guide us through the critical steps from preoperative Doppler mapping of the intercostal artery perforator to the precise design and transpositions of the fasciocutaneous. Please join me in welcoming our next speaker, Dr. Ashutosh Mishra sir, AIIMS Delhi. जोरदार तालियों से स्वागत कीजिए for the video workshop. And for this session, I would like to invite to the dais our chairpersons, Dr. Paulami Mukherjee, Assam, Dr. Akansha Bajpayee, Dr. Sharan Basappa, Dr. Priyadarshi Ranjan. Can we have on the stage, please, our chairpersons? Dr. Rahul Chaudhary sir, Dr. Amar sir, to the dais, please. Get ready everyone for the video workshop.
Good morning, everybody. So Dr. Ashutosh Mishra doesn't need any introduction. We all know him, and we look forward to his video presentation.
Very good morning. Thank you, sir, for kind introduction. And can we have the slides, please? So, as this is the first session, and you know, currently there is a lot of already agenda about the breast conserving surgery. It's now not only the breast conservation, it's about the aesthetic outcome. So now it's a demand how to achieve a good aesthetic outcome along with the oncological safety. So this is the modality to achieve partial breast reconstruction, particularly so that we can have appropriate aesthetic outcome and good oncological results. So I will focus on the two topics, on particularly LICAP and LTAP. And so what are these perforator flaps? So these are the small perforators coming throughout the skin, and we have placed a nomenclature: LICAP, lateral intercostal artery perforator flap, anterior, medial, lateral thoracic artery, and thoracodorsal artery. So these are some perforators. These are currently in use and across the world. So these are the particular locations. Here you can see if it's coming from the medial side, we call it medial, anterior at 6 o'clock position of the breast, then lateral in between 3 to 7 intercostal space, and LTAP in between 3 to 5 intercostal space. So these are, so there is an intercostal vessels arising from the vertebral artery, and at different locations perforators are coming. On those bases, we are actually giving them the name of perforators. So when it's arise from the lateral side of the chest wall, then usually we call them its lateral intercostal artery perforator. So Macaulay has given the concept of the triangle of plenty. And what is this triangle? It's formed by 3 landmarks: lateral breast fold. So this is the lateral breast fold, anterior axillary line, and inframammary fold. So here, this is the triangle we find. We can have lot of perforators, and if you are preserving that particular area, then you are ensuring that your flap is going to survive. And to localize these perforator, you can use the Doppler. So, and these are vertical perforators. So when you are using the Doppler, it should be perpendicular. So this is the idea. This is the reason. This is the triangle where you can find out the LICAP perforators, and from the lower axillary fold, 8 centimeter, 2 centimeter behind the anterior border of LD, you can find the T-dep perforator. I will show you in one of the slides. And at 6 o'clock position, so it's ICAP. So this is the LICAP perforator. You can see I have focused my probe in the triangle of plenty. It's perpendicular, and you can have. So this is a simple pulse Doppler. You can use it. This is T-dep. So in between 3 to 5th intercostal space, in between anterior to anterior axillary line, or in the anterior axillary line, you can find this L-tap perforator, sorry. And this is T-dep. When you have placed your probe at least 2 centimeter posterior to LD muscle, in between 3 to 5th intercostal space, then you can find this T-dep perforators. These are ICAP perforators in 6 o'clock positions, 1 centimeter below the IMF. And this is the MICAP perforator. For this also. So these are how you can use the Doppler, but sometimes when the patient is fatty and it becomes very difficult to localize all these perforators. So I have also given the concept of no Doppler, and usually I propagate my concept. So these are the outcomes while using the LICAP or these perforator flaps. You can get good aesthetic outcomes, appropriate ptosis, lateral swing, and appropriate position of NSE complex. And volume. So whatsoever volume if you want, you can achieve. And these are the results post-radiotherapy, almost normal skin and less visible scar. So this is the paper, no Doppler single position. Sometimes if you feel difficult, particularly the youngsters, if you want to start all these perforators flap, then by just placing the surface marking, you can actually perform these perforator flaps. So here it's important to draw the anterior axillary line, mid axillary line, and the posterior axillary lines. Your most robust perforators are into the 5th, 6th intercostal space. If you are performing the LICAP flap, you can plan a horizontal flap or lazy S incision flap, we'll show you, and then you can swing. So you can cover upper outer, lower outer, and central quadrant most of the time with these perforators flaps. So in this particular, if the patient having upper outer quadrant tumor, you can also plan the lazy S incision. This is the extension of the lower crease of IMF. And if you are doing the axilla with the same incision, always try to preserve this fat in between. That will help in giving the good aesthetic outcomes particularly. And you can just follow your patients with the mammogram. Even for the large breast and large tumors, when almost more than one of quadrant is you are taking out, so you can actually harvest larger size flap even up till the spine based on these small perforators. So these are the pre-op and post-op outcomes, and these are follow-ups. So now patients are having the 4 or 5 years follow. Even when you are dealing the patient with the post-lumpectomy scars and excisions, unknown cavity margins, you can also use propeller. When you are swinging your flap on the base of the perforator, these are called propellers, and so you can replace LD for the placement of all these. Similarly, some for the bigger lesion, and all these for lazy S incision. These are post-op pictures with almost, and you can just follow all these patients with the mammogram. So this is the small video, 5-minute video. Patients having bilateral asymmetry. Tumor is in upper outer quadrant. So here, this is the lower line is the extension of IMF most of the time, and this is the line from a lateral crease of the breast from where we are going to do lumpectomy. And with this scale, we usually harvest the flap from the posterior axillary line or the mid in between mid and posterior axillary line. So this is the length of the flap. You can roughly calculate and you can design your flap. So it's the simplest form for doing any perforator flap. You can design your laziest incision. This is the positions you can place if you are harvesting bigger flap, one bolster below lower back and one below the shoulder. You can do central lymph node biopsy or separate incision. Then can start doing lumpectomy from the lateral crease. So while doing lumpectomy, first go into the mastectomy plane and harvest the anterior flap, skin side flap, and go beyond the tumor, maintain the appropriate planes. So this is how first develop the anterior plane. So sometime if you are doing a deeper dissection somehow at 12 o'clock positions or 11 o'clock on this particular side of the breast, you can also use harmonic because that also give you good hemostasis and all these things. So here is you can see we have reached beyond the tumor. Then start doing posterior dissection, raise the entire tumor from the muscle, and then superior. When you have entire tumor in your hand anteriorly and posteriorly, then you can decide the margin on superior and inferior aspect, and that will give you good control over the margin assessment. So again, this is the posterior axillary line where the LD muscle is starting, and you can design your flap. This is the pinch test that give you the adequate idea about how much skin you can harvest, and that will not create any difficulty while you are closing the wound. So from posterior axillary line, you can just take the depth of the defect, and similarly you can place incision over your flap. And while flap is in situ, you can do the deepithelialization because at the time there is no shearing. So, and that's easy. Sometimes we are also using Humphrey's knife, or that will help in quick. So you can do with the scalpel or scissor. So it should be uniform. There should be a brisk bleeding, and then demarcate the superior border of the flap, go up till the fascia of the LD muscle. I usually prefer to take fascia along with the flap, that give extra strength to the flap. Similarly, so start harvesting from posterior to anterior, and in between. So here you will encounter the TDEP perforators. So if you are planning your TDEP flap or something, so this is the perforator. It's bleeding. You can just sacrifice because we are not going to swing flap on this. So these are the TDEP perforators. So this is the anterior border of LD. Beyond this point, you have to be a bit cautious, but you can go easily up till 1 centimeter beyond the LD muscles because there are no perforator. Your perforators are usually in between anterior and mid axillary line. That particular area you need to preserve. So just do gentle dissection, keep the cautery settings low, and with the help of right angle, you can do this. So as per the need, mobilize the flap. Here you can preserve the lateral thoracic vessels as well if you are not sure about the status of your perforators. So there will be a dual supply, and you can give good work to the flap. So here you can check immediate brisk bleeding. If it's there, then your perforators are intact. And this particularly area is called the mesentery of the flap, tissue in between anterior and mid axillary line. Then put one suture and place where exactly you want to localize your flap. So always try to fix by single. I prefer to fix by single suture at the superiormost parts because in gravity it will fall off. So this is how similarly if you are planning the flap, this is the triangle of presenti. So you can have that. I have taken hardly 2 centimeter of area for this like a flap, and over that 2 centimeter of area I am going to sink the entire flap with this much of skin island. Similarly, so after harvesting this flap, you can check immediately bleeding. So this is, you can see how finer we have gone for this LICAP harvest. And you can place the flap and design your flap appropriately. You can, if you have the ICG facility, you can also check it's on site, whether it's perfusion is at. When you are planning a skin island, then always plan in between 1/3 and 2/3 junction, because at the tip there is most of the time supply is not that good. So this is the outcome, and so just a couple of slides about the lateral thoracic artery perforators. So this is the lateral thoracic vessels. If you are doing axillary dissection, just look for this lateral thoracic vessel, and it gives some perforators to the skin. So this also helpful for, so these are the perforator for the lateral thoracic. I have harvest anterior flap and detached from the lower sides once I am sure that I have taken out that perforator. And this is the immediate assessment about the supply of robustness of your perforators. So this is the perforator here you can see, and you can swing your flap for all these things. So thank you so much, and these are the perforators, quite helpful for partial breast reconstruction. This is annual oncoplastic workshop we usually conduct, and for next year we have released the flyer and we are taking the registrations. Similarly, we have moved beyond and we are going for robotic breast surgery for this also. This year we have closed the registration, and for the next year we'll start doing registrations very soon. Thank you so much.
Thank you, Ashutosh. Great video, good demonstration of the perforators. And I always say to my juniors that when they are doing the mastectomy, they should look for these perforators.
Exactly.
That's the best way to learn, I think.
Yeah.
Any questions from the audience?
Yes. No, basically most of the time we usually record for demonstration or something. So if you are placing your skin island in between 1/3 and 2/3 junction of the flap, most of the time it's secure. And particularly if you are raising the MICAP flap, then most of the time there is a poor vascular supply at the tip of the MICAP. But in LICAP and LTAP flap, most of the time it's perfect and supply is adequate. So it's not needed, but if you have the facility, definitely you can check.
Thank you.
Thank you, sir.
Now, coming to the next presentation, I invite Dr. Diptendra Kumar Sarkar. He will deliver on reconstruction with acellular dermal matrix.
Good morning, everyone, and thanks to VP for organizing such a fantastic conference that you have at 9 o'clock the hall is filled, and at 10 o'clock in the evening also the hall is filled. That's really a very enthusiastic sign about academics these days, which is a rarity, to be very honest. Now I'm going to discuss about acellular dermal matrix, and many of you might wonder what this exactly is. Now, I don't have any disclosures to make. Now, this is the traditional way by which we used to do implant-based reconstruction. Now, once you do a mastectomy, so naturally those will be skin-sparing mastectomy, because you need an extra skin if you want to put in an implant inside. If you do a traditional mastectomy, the skin is so tight that you won't be able to place in an implant inside. So you plan the amount of volume that you want to give back to the lady, and then you do a skin sparing mastectomy, and then people used to put in an implant inside. Most of the times it was just beneath the pectoralis major muscle to hold the implant or to make the pocket complete. What people used to do, used to take out the latissimus dorsi muscle from behind and put it in front and complete the pocket. So the pocket would necessarily constitute above by the pectoralis major muscle, beneath by the latissimus dorsi muscle, and in between the implant would be placed in that particular pocket. So people were happy with it, but the issue was definitely taking the pectoralis major from behind and weakening the back to the certain extent, and I am told certain classical singers will actually have some difficulty in singing in high pitched voices. So this innovation came around 1.5 decades back. For postgraduate trainees, you have seen meshes being used in hernia. Now this is actually a mesh. Now what is being done? It is taken either from the bovine or the porcine, or now you have human skin as well being harvested, and then you take out every single element from that skin, and what remains is the collagen only. Now this collagen has lost its antigenicity and can be used as a sort of human or a bovine or a porcine material mesh, which is going to replace the latissimus dorsi and complete the pocket beneath the pectoralis major muscle. So here we are going to see that after a mastectomy is being done, once again I will come to that division later on, that there are two ways you can put the implant in front of the pectoralis major muscle, which is called a prepectoral implant, or you can put it underneath the pectoralis major muscle, which is called a subpectoral implant. The advantage of this is that if you have done a proper skin sparing mastectomy, that would require extra 15 minutes time to reconstruct the breast immediately on table, and then the patient goes home with a breast which is completely as per the opposite breast. Now here you see, this is the pocket that is being created. This is the pectoralis major muscle, and underneath there is a pectoralis minor muscle. So what I am doing is I am gradually creating a pocket. Now when I create this pocket, I go to the medial most extent. Now this is the lateral aspect. At quite often, if the pectoralis major muscle is quite tight, you might have to incise the medial end so that you can accommodate a larger implant in the subpectoral space. Now you have completed more or less the pocket that you see here. Now this is the pocket intact. So this is the space which we have created. The purpose of the space is to accommodate an implant. Now as you see here, that's the inferior edge of the pectoralis major muscle, and that's the big pocket that you have, and that's the skin sparing redundant skin, and therefore that is the place where you wish to put in the implant. Now this is the ADM, the acellular dermal matrix, what we quote unquote is a mesh. Then you put it and soak it for at least say 20 to 30 minutes time. It swells a bit, and then this is the implant which you calculate based on the opposite side what would be the approximate volume. To be very safe, you actually put it in a povidone iodine solution for some time. I don't know whether it works or not, but people have used it and I have been traditionally using it, though I do understand that doesn't really make big sense. Now after that, once we have, now we are stitching this mesh which is being stitched in the proposed or previous intramammary crease. And as you find, you usually generally use a non-absorbable material or at times a delayed absorbable material, and you stitch it at the inframammary crease area so that you are able to create an pocket in which the posterior, the most inferior aspect is completely fixed and rigid and does not allow the implant to slip off. So you see, this is something which can be replicated tomorrow morning. The only barrier, I suppose, is the cost. But if you are able to overcome the cost, and if the patient agrees to use this, you can look at this video and go back to your clinic tomorrow morning and do a reconstruction using. Now the pocket is ready. Now as you see, the implant is being put inside. So the implant is in the subpectoral space. Now you are going to take this and fix it the way you see that that's the pocket which is being completed. So it's pretty easy at this point of time. The only concern now, as we are going to start the stitching of the implant from the medial aspect across the pec major muscle to the lateral aspect, is that you have to be very careful, in the sense, if you are a bit rash, you can end up in pricking the implant. That's my only area of concern, that then the whole procedure is gone, and to be very honest, 50,000 rupees goes into drain. So you have to be very careful you do it. In the lateral aspect, as you go and fix and completely to make the whole thing complete, so that the implant is hold at that particular position. So you can have a continuous or an interrupted one, whatever you choose to. The suture material essentially is a non-absorbable material, polypropylene. We have used with PDS as well, and it's almost the same. Whether you use a PDS or you use a polypropylene, didn't make any difference in our practice. So as you see, you just go on completing the whole thing, and then after you have completed the whole thing, you are going to put in a drain that you would usually put in otherwise in any mastectomy. Now you look at this. This would take you 15 minutes to create to fix the mesh, and maybe another 15 minutes to put in the implant and complete the suture, and the whole reconstruction is ready immediately, and the breast is ready for primary reconstruction. Now this is immediate result in one of our patients who have got a large volume breast, and she wanted a primary reconstruction and a reduction mastopexy on the other side. So it looks quite good. I mean, whether you are going to preserve the nipple areolar complex is a completely different indication. So most of the times it is a non-nipple sparing mastectomy. So you go on and achieve this. This is an immediate result of a patient who was 36 years lady, and the reason I have put in is it is a picture from 1st July 2021, when we used the first ADM. A day before it was used in Sanjit Center, and on 1st July we used it. That was after, or it was 2022 possibly, when it was first licensed to be used in India. And it was created by a gentleman who is an Indian in the UK, and we used it, and it works very well. So as of date, we have been able to use 15 cases. There are larger numbers from Sanjit Center and certain other centers. The biggest issue with this is the cost. We have used only 2 patients with prepectoral implants. Prepectoral is very good, but the only issue is that of cost. Most of the patients would not like it, afford the cost. But if you are able to use that, it gives a better projection of the breast, and cosmetically it is far better, and it is easier, to be very honest. Whereas subpectorals are less costlier because the ADM is less costly, and you can put in, but the problem is it looks more flatter. It doesn't give the natural shape of breast that you can achieve with a prepectoral implant. As of now, I have one patient in whom I had to take out the implant. That was the most ghastly thing that can happen to a lady who had been thinking of doing a fantastic reconstruction. And then, of course, we later on put in the latissimus dorsi myocutaneous flap, diepithelialized flap to get a bulk. But you can never achieve what you can achieve with an ADM. Well, the number of patients who underwent radiation around 1 year or 2 years back, when we started, we were very, very unsure whether to use radiation or not. But as of now, in 4 patients that who have received radiation, it did not affect the outcome of the reconstruction with ADM. The patient satisfaction is very good. 9 out of 10 patients are very happy. Well, but as I said, there are certain things which can come up in discussions. The mean duration of stay is 5.5. The reason why I would keep these patients for a longer time, whereas mastectomies can be discharged in 48 hours, is because of the fact that if there is a seroma, in Indian practice, very difficult to get back the patient. I do an ultrasound to be very sure that after 2 weeks that there is no seroma. If there is a seroma, I ask the radiologist to aspirate it under ultrasound guidance. I would not go in blindly for this. So thank you very much for your patient hearing.
Thank you, sir, for your elaborate discussion on ADM used in breast reconstruction. Is there any query or question from audience?
Yes, sir.
Excellent presentation. I'm not a breast surgeon, I must announce that first. But I have got my experience with this cellular German matrix while doing perineal reconstruction or incisional attachment. Just one question, because you mentioned that these elements come from bovine, porcine, or human. Do you discuss with your patient about the origin of these kind of mesh you use?
No,
because there might be religious concern.
So to be very honest, then we need to discuss about catgut as well. Okay, that also comes from an animal intestine. Now these, at the end of the day, does not have the origin of the animal from which it is being taken, because it is processed so much that nothing is left of the original animal. What remains is the collagen. You are just taking the collagen. So no, I don't discuss, because there is no point also, there is no reason to discuss. And only in the US, I have seen people are using human. Then again, the question will come whether it's a Christian skin or it's a Muslim skin or an Hindu skin. So I don't go into this controversy. I would accept the technology as it is.
The reason I have asked is when I was training as a junior resident in Cambridge University, I asked this to one of my consultants, because we were using fistula plug made of porcine collagen. And actually that changed the practice there. We started discussing with the patient, because those are like, litigious society where the litigation is common. If anyone get to know that we have used those kind of elements which can alter their religious belief, but I'm not sure about Indian scenario.
Can I interject here? That question is, in the UK that was a problem. When we started, it was Stratis. And that Stratis was a porcine material. So initially Muslims were not very keen on that. But Central Mosque of Birmingham, that endorsed the product, and Rishi might remember that. They endorsed Stratis, saying that it's completely acellular, so there is no pig left in that.
Absolutely,
Yeah.
I remember that.
Yes, so that's why it was then used very commonly, even in Muslim patients. Even so Birmingham has got a large Pakistani population. And it was being used there for breast reconstructions.
Thank God you have got the endorsement. We are happy to proceed. If
Yes,
anybody
exactly.
asks, I will get this. This is an endorsement from some religious institute.
Sir, one question. Sir, you have shown ADM was entirely fixed to pec measure. Pec measure is always moving. So, is there any chance of loosening of the anterior suture and extrusion? For that, what we can do so that future loosening and extrusion is prevented?
Well, pec measure, to be very honest, if you take a good bold bite, nothing is going to change. As of now, we didn't find any single patient when the implant went out. If it goes out, then it is due to rejection, it is due to infection or improper fixing. But as such, if you follow the standard techniques, there is no reason why the implant should come out because it loosened. What happens that initially, to be very honest, we haven't seen much, But what will happen is initially if you're putting a subpectoral implant, many of my patients, almost all of them came up and tell that the medial fold was too prominent. Because I was trying to push it more harder, I thought it should not come out. Now what happens, it settles with time, there is a natural ptosis, and that the medial crease actually settles down and the patient has got a more happier breast. Okay.
Thank you, Diptendra.
Thank
that
you.
was a very nice presentation.
Thank you.
Just one quick question. Do you always use smooth implants or whatever is available?
That is what is available, so I use that only.
Okay.
Okay. Thank you.
Thank you very much.
We welcome Dr. Navneet Kaur. Next presentation, round block.
Okay. So good morning. I'm going to talk about Benelli round block mastopexy, and I think this is the most commonly performed oncoplastic procedure. Very easy to learn, and I think this is the procedure one can see in a workshop a day and go and practice the next day. It is as simple as that, and in fact I asked Dr. VP that yesterday, did we see the cases of round block, and he said the appropriate patient was not available. So I hope this video will help you close that gap. I actually put up a modification of the original technique thinking that you would already have seen the conventional round block, but even the modification is only about the marking of the skin. So practically the procedure remains the same in terms of its details as to how to perform it. So round block technique is actually originally a plastic surgical technique for the purpose of breast lift or correction of ptosis, where the volume was not to be reduced. So this was described by Benelli in 1990. We all are familiar with excisions of small lumps by using periareolar incisions or circumareolar incisions. But the limitation there is a limited access. If you are doing a fibroadenoma where we just need to enucleate, reach that area, that kind of incision is perfectly fine. But if we need a little wider exposure of the operating site, ensuring that we are getting a tumor or a cancer out with adequate margins, we need little more space to access that. And that is the flexibility the round block technique offers over a circumareolar incision. So this can be applied to any quadrant of the breast, irrespective of the size. Yes, obviously it is only a level 1 oncoplasty. So anything which is less than 20%, 25% is perfectly easily managed by this. If there is a bigger tissue loss, then we will have to think of some kind of a reduction or a replacement. In this technique, the advantage of increased access is gained by using two incisions which are periareolar or circumareolar, what we call as donut incisions. And by the design of the outer circle, we can decide that how much skin from which part of the quadrant of the breast we can modify to increase our access or kind of match the discrepancy with the opposite side. So it essentially involves two incisions around the areola, and their sizes, the optimal gap is say about 2 centimeters. It should not be, outer circle should not be bigger than the inner circle by more than 2 centimeters. But in some modifications, and I'll share the video of that only, where we had too much of excess skin, and for that we can change the design of the outer circle. The two critical points that are relevant or important in this technique is that we have to ensure that once we have sutured back the two circles that we have created, the areolar size does not increase is not expanding. To kind of control that, there is a placement of a suture which is called a cerclage suture. It is placed in the dermal tissue that is depithelialized, and at the end of it we tie it in a manner that the size of the areola on this side matches with the opposite side. And normally a suture like PDS is used, which is delayed absorbable, so by that time the scar will mature. Because widening of the scar is one of the most, I would say, adverse effects or sequelae of this technique if it is not, this kind of a suture is not placed appropriately. So in this technique, whichever quadrant of the breast the tumor lies, we can access by only, say, we can do almost 180 degree. Half the circumference of incision can be cut through the dermal kind of a tissue for reaching to the site of the tumor. But if we cut more than that, then we may end up with the devascularization of the nipple areola complex. So I think that part is critical when we are making an incision into the breast tissue to raise the mastectomy flaps. Having done that, we go to the site, get the tumor out by the conventional methods, orient, put the tumor beds, clips in the tumor bed, reapproximate by doing a dual plane mobilization. That is, we create a plane between the dermis and the subcutaneous tissue and prepectoral space also to kind of increase the mobility of the glandular flaps so that they can be reapproximated. And if required, the patient is keen, one can do a contralateral symmetrization, which actually is not much of reduction, it is more of a mastopexy to reduce the ptosis. So in a patient like this, we can do the surgery with a cosmetic result. Yes, there is elevation of the NSE on the other side. One can see a little loss of volume in the upper inner quadrant, but overall appearance is acceptable. And that is, I think, what is the simple procedure with a simple outcome, which is satisfying to the patient. We can use little modifications. This is called tennis racket extension. So if the site of the tumor, the skin is too close, it is not wise to create a plane in this area when the skin is so closely tethered. We can just extend the incision, get the tumor out, do the closure and create a breast which is normal, a good shape of or mound of the breast with a NSE which is placed appropriately. So what I'm going to show a video is that of a modification in which there is a huge discrepancy in the two breasts, and this is done for a benign condition. In fact, this technique is valid for benign as well as malignant. A little larger fibrinomas which are creating a size discrepancy can also be managed with this. So what we see here is the modification of the outer circle, and the excess skin that is there can be excised, and then we are able to. So this is one case in which the same principle of modification has been applied. We can see there is a big discrepancy. She is a young girl with a large fibroadenoma, and this is what is the design of the outer circle. All this skin is going to be depithelized and buried, and we can have an outcome. So immediate post-op, you can see a lot of wrinkling, but in long-term follow-up that disappears. So this is one video that I'll show in a patient, and then show her pre and post-op picture. So this girl again had a large fibroadenoma on one side. So she's a young girl of age 14, so breast was still developing, and I did not want to do too much of dissection. So intent was to just get the fibroadenoma out, and the remaining breast tissue will grow in due course of time, and then the symmetry and other things can be, if some asymmetry is left, that can be addressed. So this is the step of depithelization, and you have seen this is the most basic step of any oncoplastic technique. We are doing light cap or reduction mammoplasties of different kinds. So I have kind of depithelized all around the areola and NSE, the excess skin. So now this is just the step of mobilizing the fibroadenoma from underneath the skin over the chest wall, pectoralis muscle. It's kind of an enucleation that we do for a simple fibroadenoma. It's not a malignancy, so I'm not really keeping a finger on the tumor and trying to get an extra margin of 1 centimeter around it. But if it is a malignancy, there's obviously you have to be very careful with the adequate margins all around. And also the orientation of the specimen before the tumor gets out of the bed, because once it is in your hand, then the problem is to kind of accurately mark the margins, superior, lateral, whichever protocol is followed at an institution. So yes, there is a much bigger outer circle because of the excess skin that was there. So pre-placing some sutures before doing the continuous running is what is desirable. So I tend to close the closure in 2 layers. One is the deeper layer where I use vicryl sutures, and for the subcuticular running suture I use monocryl 20 on a cutting needle. So at the end of the procedure, we can see there is a lot of wrinkling around the incision line. But I'll show the result of this girl and what is expected in the long term. So this is the pre-op and the post-op of this girl. So she's a young girl. There is no need to kind of think of any symmetrization, because after the adenoma is out, the remaining breast tissue is going to expand and grow to a normal size. And in this way, we are able to with a very simple technique of just the increasing access by a donut incision, doing a closure, and getting the tumor out. If malignancy with the margin, and if it is a benign tumor, just a simple enucleation kind of a thing. Thank you.
Thank you, ma'am, for this beautiful presentation. Is there any query from audience?
Dr. Navneet, I have a query for Dr. Navneet. This particular case, it was done for a benign lesion, so you have not mobilized the pillars like what we would have done. Yeah. So how did you deal with the seroma?
She had no seroma. I put a drain there in the bed, and after 2 days...
just another. So if you do put a drain, you bring it through the same incision?
No, it is in the inframammary, or whichever is the fold which is closest.
Right.
So I think it was the inframammary drain which was placed. Obviously there will be some seroma in the bed. Your question was about the pillar mobilization.
No,
pillar mobilization.
My question was about the seroma in this particular case, because you did not need to mobilize the parenchymal pillars.
Right.
That was all.
Yeah, because when we are in this case, there is a much bigger breast on one side. For a tumor, the breast size will be similar on both the sides. In that case, obviously, when you take out even if 20% or 15%, you have to mobilize the glandular pillars from either side and then close the gap. In fact, I removed my original round block and put the modified, because I had thought that the round block would have been shown, and this being the most basic, it will be easily understood. I have the video on the other pen drive, but more or less, yes, once we have created a defect, in this case there was already an excess tissue, so there was no loss which needed to be replaced. But if some loss is to be kind of covered, then mobilization is good enough. And if it is obviously more loss of volume, then some kind of a replacement, then round block may not be the appropriate choice for that.
With regard to your question, Dr. Polemy, as to how do you get rid of the seroma, so in benign conditions on excising the lesion, usually there's no cavity, and if there is a cavity, using a support bra or a pressure dressing actually helps, because we're sort of reducing the space for the seroma to accumulate.
But even if there is no large defect, there will be always some oozing from the bed. So for large fibrinomas also, leaving a mini vac for a day or so is a good thing, because if you have a large of, a bit of bleeding in the bed, the ecchymosis and everything kind of discourages the patient a lot, because they see a ecchymotic patch there and the cosmetic appearance is compromised. So leaving a small drain for 24 hours this is what I generally practice, even if there's a good hemostasis on table.
Thank you, Dr. Navneet. That was brilliant. Shall I go? Okay. The next one is SLND with Advancement Flap, Dr. Akash Kumar Singh.
Good morning, everyone. Sentinel lymph node is the first draining lymph node And doing SLNB is nowadays not a new thing. And there is a shifting paradigm from radical mastectomy to MRM to breast conservation, axillary dissection, now reducing to SLNB. We know the 75% of breast drain into axilla, and no accurate imaging modality for early disease. We do USG, PET CT scan, many things. And predominant axillary drainage, other drainage are intercostal, interpectoral, periclavicular, and sometimes abdominal nodes also. SLNB, we know it lessens morbidity associated with ALND, and many trials are showing now the importance of SLNB now. There are some problems associated with SLNB, the false negative rate, which we can reduce with many things like adding one dye to two dye, double dye method, and ultra sectioning of node, sentinel node by pathologist. And with the increased technical expertise, it has a good sensitivity, more than 95% every time. And there's current guidelines for NCCN guidelines supporting doing sentinel lymph node in all N0 cases. Injection procedure, it is either superficial, intradermal, subdermal, subareolar, periareolar, and also deep intratumoral and peritumoral. All techniques are equally productive and satisfactory. Obviously, sometimes there is SLNB failure. I mean, we do not get the desired nodes. In that case, the ultimate assort is to do ALND. So, this is a short video demonstrating. We usually use dual dye method, and usually methylene blue and ICG we use. Methylene blue we usually inject subdermally below neck. Amount we take almost about 3 to 3.5 ml. 50% of methylene blue we inject peritumorally also. And after that, a gentle massage for some time, and 1 ml ICG we take, and we inject 0.25 ml in each quadrant of NAC, and we wait for almost 5 to 6 minutes. The time starts from injecting methylene blue to making incision in the axilla. Almost it takes 2 to 3 minutes to illuminate the lymphatics after injecting ICG. You can see the illumination of the lymphatics there, and the lymphatics are interconnecting and well propagating through into the axilla. Sorry. We trace the lymphatics up to axilla, and we tend to make incision about 5 to 6 minutes after the initial injection of methylene blue into the subareolar space, and overall we are prepared for getting blue node and the illuminating fluorescently illuminating nodes in the axilla 6 to 7 minutes after injecting methylene blue. Sorry. Consistent position, we get these blue nodes. You can see the blue nodes. Is usually it has been explained in literature also. It is usually found in and around the lateral thoracic artery, and we tend to get these nodes always somewhere around lateral thoracic artery branches, and we then localize this by this handheld camera. You can see the beautiful lymphatics draining into the axilla, and those illuminating nodes in the axilla. Thank you.
Thank you. That was a good demonstration. Any questions from the audience?
Methylene blue uptake, should we proceed with the axillary lymph node dissection or not?
If there is no availability of any dye.
No. So if on ultrasound and mammography lymph node is not palpable, that is clinically N0. And in methylene blue injection, no node have taken color with blue dye. Should we move with the axillary lymph node dissection?
Yes, I have told that sometimes there is a failure of this technique, and in case of that, we have to go for axillary lymph node dissection.
Till which level? All the three or only one?
No. Level 1 and 2 are recommended. It's the standard guidelines.
I'm sorry, I didn't understand that question. You mean
suppose
that
if there is a tumor of 4 into 3 centimeter size, and we have injected the methylene blue, but there is no uptake in the lymph node. Should we proceed with the axillary lymph node dissection, or we should leave the lymph node?
No, we should do a lower axillary sample in that case. Especially if you have frozen section, you can get that done. And if there is any positivity, then we should proceed with.
If there is no availability of frozen section, then till which level we should move with the lymph node?
We can still do low axillary sample if there are no suspicious lymph nodes there, and then wait for the reports.
Thank you, sir.
So basically, you need to dissect out the axilla below second intercostal nerve. So that's the tissue you need to take out if you are not getting any uptake in this lymph node. So for adequate central lymph node, there should be at least 1 to 2 sentinel lymph nodes should be there. To reduce the false negative rate, it should be less. False negative rate should be less than 10%. For that, 3 lymph nodes are adequate. So if you are not getting anything, then at least 2 low axillary sampling below second intercostal nerve.
Breast conservation surgery and axillary surgery are two different things. Once again, Ashutosh.
So can we move with the breast conservation surgery followed by radiotherapy?
He's asking, can we spare axilla, not
So that's the basis of 3 centimeter size. Yeah, that's the basis of NCMA trial. 10% they have included T2. So definitely if on axillary ultrasound there is N0 lymph nodes, no uptake, clinically no lymph node, yes, you can. As per the NCMA trial.
So I think you are presuming that if the methylene blue is not reaching, the lymph nodes are not involved. Is that the presumption?
I'm confused a little bit.
It is not. It is not, because lymph nodes will anyway be identified by the methylene blue, whether they are involved or not involved. Right? It is not that if the methylene blue is not reaching, lymph nodes are not involved. Is that the methylene blue is not able to reach there because it is, it has a higher molecular weight compared to the isosulfan blue. That is why that was used initially, but methylene blue can be used with good massage for 7-8 minutes, and it is, the manual massage pushes it to the lymph node. So lymph node must pick up methylene blue whether involved or not involved.
Okay, that was my doubt.
And in the lower axillary sampling, you easily get 6 to 7 nodes. The average number of nodes harvested, this is the fat pad below the second intercostal nerve, and lower boundary is generally the angular vein, which is the branch of the thoracodorsal vessel. So in that much space, which is generally between 2 to 2nd, 4th intercostal space, there is a fibrofatty tissue which has a lot of lymph nodes, which are the first draining group of nodes. So if you take out that fat pad, you will get at least 6 to 7 nodes harvested from there. That is the data from TMH. That is also our practice also. And if that is enough sampling. If you clinically felt that lymph nodes were not palpable based on your clinical and imaging, then we are having anyways low axillary burden, right? And 6 to 7 nodes are good enough for sampling. If they come negative, fine. If something is involved, even low volume involvement is there, 1 node, 2 node, that can also be covered by radiation. So that is what is the current, this thing of low axillary burden or metastasis can be covered with radiation therapy, because that will be part of BCS anyways. And if it is still higher, more involvement, then you can irradiate the level 2, level 3, based on many trials which tell us that radiation can be complemented with sentinel node if the nodes come positive later on.
Actually, if the patient is young, can we completely skip the axillary lymph node dissection and go for other modalities?
As per no current guideline says that. No
because
current.
In young patient, the lymphedema will be
I think
troublesome
the lower
in long
axillary
term.
sample tissue out at the most give rise to some edema of the breast. It doesn't disturb the lymphatics which are draining the arm. So
may I suggest that we continue with this discussion at coffee?
Yeah.
I mean, Dr. Navneet has given a beautiful explanation, but we'll proceed with we move on with the next presentation.
Thank you, sir.
Face after methylene blue, any
there
adverse
is
reaction?
Chances of 1% chances of allergic reaction after methylene blue.
And other adverse reaction, how do you manage that other than allergic reactions?
Whenever there is allergic reaction, we accordingly manage the patient for allergic reaction, and then wait for the procedure. If all the allergic reactions are managed at the table, then only we proceed for the surgery, and if it is severe, then we abandon the surgery at that time.
The risk of allergic reaction with methylene blue is very low, almost unheard of. It's more common with a blue dye, which I think is used in the West, in the UK, isosulfan blue, which is not used in India. The most common side effect that you can say of using methylene blue is less than 1% chance of skin necrosis if injected very superficially.
So what we'll do is we'll continue with that discussion as well over the coffee. We'll just move on with the presentations. So next one is by Manjula, endoscopic breast surgery. Thank you.
A very good morning, everyone. Thank you so much, Dr. Deshpande, for the introduction. At the outset, I'd really like to thank Dr. Singh for this kind invitation and also the opportunity to present this video. So endoscopic nipple sparing mastectomy is the new kid on the block. It is a method of minimally invasive breast surgery apart from robotic, and this is a technique that is can be easily adopted in the Indian scenario. So preservation of the nipple areolar complex we know is key for promoting psychosocial sexual well-being and cosmetic satisfaction, and nipple sparing mastectomy has been popularized since the 90s for prophylactic and select therapeutic indications. Now, the oncological safety of nipple sparing mastectomy when done correctly has also shown comparable survival outcomes. Thank you. Now these are the traditional, so why do we need a minimally invasive technique? Why did that even come about? So apart from your inframammary and your lateral mammary crease incisions, these are some of the typical incisions that have been described for a nipple sparing mastectomy, which causes scarring over the surface of the, the breast, which is why people started looking for a minimally invasive alternative. And the classic, I think the highlight of MIBS is that it is characterized by small scars which are usually hidden in the lateral mammary crease or the inframammary crease, ensuring improved cosmetic outcomes, patient satisfaction. The incision is located away from the nipple or the periareolar region and giving us the same results. Now, before we go ahead with a nipple sparing mastectomy, it's very, very important to ensure that oncologically, if we're doing this for a patient with cancer, oncologically, the patient falls under the required criteria. Otherwise, this can be done for a prophylactic indication. So let's look at the technique. What are the instruments and accessories that one would require in order to start this procedure in their setup? So whatever is required for a routine laparoscopic surgery is all that we would need. There's no need to get any additional fancy equipment except for something which is known as a gel port. So you have the vision system, an endosufflator, power LED, laparoscopic instruments, and what you see on the left is a gel port. That's a used gel port, and that's why you can see some of the betadine which is still there, and the cannulae that come along with the ports that come along with the gel port. So patient is positioned typically in a supine position, but the marking is done with the patient in the upright position. The arm is placed at 90 degrees. Some surgeons also like placing the arms of the patient by their side with the elbow slightly depressed, so it will be at an angle and the arm will be suspended using a towel. But the challenge with that is, especially in a patient with cancer, it's difficult to address the axilla. Secondly, because of that angling of the arm downwards, it can result in brachial plexopathy in some patients. They can present with neuropraxia post-operatively. Now these are the two solutions that one needs to keep ready prior to starting the procedure. A tumescent solution. We did not have access to a ready-made tumescent solution, which I believe is available in the West. So this was how we made it. And a methylene blue jelly. Basically you mix 10 ml methylene blue with 30 grams of xylocaine jelly to make that mixture. So let's take a look at the video. Right. So patient marking of the breast footprint has been done in an upright position. The tumor has been marked as well. Grade 2 ptosis, B cup. Patient with a luminal A subtype tumor. This is the positioning. So the first thing that we do is we mark the breast footprint using the methylene blue jelly, and this is in order to help us to identify the footprint of the breast, hence telling us where to stop dissection once we're inside, because once we actually go and start dissecting, everything is just a red or a pink mess. Next, we mark the incision, typically 3 to 5 centimeters, with the lowermost, the mark coming up to the nipple. The next step, once we take the incision and deepen it, is we do a hydrodissection using the tumescent solution in the mastectomy plane to help us with dissection. And then This step is where we insert the Metzenbaum scissor along the plane of where the tumescent solution has been injected in order to widen the planes. So this helps us with endoscopic or robotic dissection. Now the way to do this, to introduce the Metzenbaum scissor, is you introduce it in when it's closed. So you don't open the scissor, you introduce the scissor when it's closed, you reach up to the medial end and then open it and you pull it out. And this has been specified in order to minimize the damage. That's me just cutting some of the superficial fibers before I go in. And then once that is done, we create a space immediately below the incision in order to introduce the port. So I'm introducing the gel port there. Now placement of the ports into the gel basically has to be done in a pyramidal fashion to prevent the arms from colliding with each other. And the gas insufflation. This was, you know, I actually had a lot of problems in this step because the port wasn't really working that well. So there was a gas leak. The pressure, you'll have to insufflate it up to 8 mm carbon dioxide. So I had to change my port, you know, finally, because it wasn't, oops. Okay. So that gives you a very good inflation by which we can actually see. I'm going to try pausing this again. I hope it doesn't stop. Okay. So now at this point, when I was trained to actually, so there are 3 instruments. You have the camera, you have the grasper, and you have a hook or a scissor, whatever you may prefer for the dissection. So what we've been told is you ask the assistant who is standing to the surgeon's left-hand side to hold the camera, while we, the surgeons, we hold the grasper for the traction, and we hold the hook or the scissor for the dissection. I, however, found it easier to have control in my hand. So I found it easier to hold the camera. So I held the camera and I held the scissor or the hook while I used the grasper, held on to the, you know, positioned it and then gave it to my assistant in order to give me the required traction. I preferred using the hook for dissection. I didn't really like using the scissor all that much. And most of it is quite straightforward because initial dissection has already been done. You know, when you do the hydrodissection, you put the Metzenbaum scissors. So there are a few fibers that are holding on to it. And I think the challenging bit is when you come to the nipple areolar complex. So as you can see, my assistant is actually pushing down from above and showing me where the nipple is. So I'm grasping the nipple under tissue. So whether you're doing this procedure for a prophylactic condition or whether you're doing it for a cancerous condition, it's very, very important to send a nipple under tissue for a biopsy to ensure that there is no, that it is negative for malignancy. And usually 2 samples are sent. So you send the outer tissue. In case the outer tissue comes positive, then you send the inner tissue. If the inner tissue also comes positive, then the nipple is excised. So that's us sending we've taken off the nipple under tissue and we sent it for frozen section. And interestingly, in my patient, it was an early breast cancer. We'd done a mammo, MRI. Everything was clear, but interestingly, the nipple under tissue, both samples came positive for malignancy. it is important to remove the specimen in toto, not in bits and then stitching it up. So from the outer aspect all the way to the medial aspect, the entire breast has to be taken in toto. Care has to be taken to maintain adequate flap thickness, neither take out too much nor leave a lot of breast tissue inside, especially for a patient with a malignancy. So MIBS in India has yet to become a mainstream technique, mainly because is there a need? You know, there's limited working space, superficial nature of the breast lesions. Honestly, you know, we can sort of attempt the same thing using a slightly longer incision, low morbidity rates of breast surgery, low levels of pain associated, longer operation time than conventional surgery. And breast tumors can also commonly be accessed through smaller incisions. And while it has been approved for prophylactic indications, our concerns are mainly with regard to malignancies. So, you know, with regard to the surgical margins, locoregional recurrences, the smaller incision, and you're taking out such a large specimen. So we still need concrete evidence and long-term evidence to prove the safety of this technique in cancers. But we do have some meta-analysis and some data coming in support of minimally invasive breast surgery as well. So just the take-home message in this case, it's very, very exciting when a new technique, you know, comes onto the scene. It's very important that we all learn these new techniques, but also ensure that we do patient selection with care. We treat the right indications. We closely collaborate with our colleagues, plastic surgeons, etc. Keep a mind on the flap thickness, which can vary as per the patient adiposity, and always, always adhere to oncological principles which come first. Thank you very much for your patient listening.
Thank you, ma'am, for your nice presentation. Is there any query?
So for endoscopic or you minimally invasive in general, for endoscopic, people have said it takes around 4 to 5 hours. When I attempted it, it actually took me 3 to 3.5 hours for the mastectomy, which is still longer than a conventional mastectomy, which may be 2 hours. So it depends on the learning curve. It depends on how soon they sort of get acclimatized to using this, but definitely a shorter learning curve than robotic.
Yeah. And then post-operative reconstruction is also important.
Yes, post-op reconstruction also needs to be done either by autologous or by implant. I usually go for autologous reconstructions. It's a gold standard.
So that way, you can compensate for the time lag.
Yes, yes, yes.
Thank you.
Dr. Manju.
Hi.
Hi. In terms of body habitus and cup size, how do you choose the patients? Or do you have your you have criterias of your own, apart from the oncological indications?
Yes, so for minimally invasive breast surgery, it's preferable that patients, the breasts are not excessively ptotic and small to medium-sized breasts. In this particular patient that I chose, it was a grade 2 ptosis. I got away with it, and yesterday I was actually seeing, even though in literature they say small to medium sized breasts, I think we should stick to it, but I do know of colleagues who have been attempting minimally invasive surgery for more ptotic breasts, and they have good favorable results. Also, I think when we look at body habitus per se patient selection, those patients who can tolerate breast reconstruction. Anyone with contraindications to that, we need to rethink.
Thank you, Manjula. In interest of time, we'll...
Yeah.
Yep.
Just a minute. So as of now, there is a consensus statement across the globe. So cup A, B size tumor should be in depth of more than 1 centimeter for adequate dissections, and mostly for the invasive biology, not for lobular and all these. So these are some criteria: cup A, B size, minimal ptotic, more than 1 centimeter from the skin. So this is the as of now consensus statement.
Once again, continue with the discussions over the
thank
coffee.
you very much.
So thank you very much. We'll move to the last presentation of this session by Dr. Sanjeev Agarwal. He is going to present on oncoplasty planning in the OPD.
So I think we are running with the oncoplasty mania from the yesterday. So you have seen all the techniques almost. So initially I was scheduled to talk about batwing, but you have seen the batwing yesterday, nice batwing done by Dr. Resi and Dr. Amar. So give me 20 minutes time. I'm doing 2 presentations together. So it's not a 10-minute time. So what I feel that it's very essential to plan it well if you want to execute and achieve the good cosmetic outcome. So in the OPD itself, when you are seeing patients, the whole thing planning starts at the OPD in the first visit itself. So this history you have seen, mastectomy, breast conservation surgery and oncoplasty. So it started from the Halstead, then Sir Bernard Fisher and then Umberto Veronesi. And they have changed the concept of the mastectomy to the breast conservation surgery. But why this workshop, this whole done by the Dr. BP Singh and team? We are doing breast conservation surgery 15 to 20 years before, but we were achieving this outcome with the simple wide local excision. So no pillar mobilization in the first patient. You can see the dimpling after radiotherapy. And in a large ptotic breast, you have done a simple wide local excision with the simple closure. And you end up with these outcome. Yes, we have done breast conservation surgery, but the cosmetic outcome is not acceptable even for you. Patient will not say anything probably, but you will be not happy by seeing all the outcome what you have done. So as I said, the shift is from the oncoplasty is as the name suggests, think about oncology first. So wide local excision should be as good as the normal wide local excision. Don't compromise on oncological safety for giving good cosmetic outcome. And the principle of the oncoplasty are these 5. So complete tumor excision with the negative margin. Try to preserve breast contour and symmetry. You need to think for the radiotherapy also. In certain type of the breast, radiotherapy side effects are more. And if you plan it well in the OPD, chances of having a good cosmetic outcome after radiotherapy is a little bit more if you are not planning it well. Maintain nipple areola complex and achieve good cosmetic outcome. So what you should do in clinical assessment in the clinic, try to record these findings in your clinical assessment, and it will help you in planning oncoplastic breast surgery when you are taking the patient to the OR. So examine both in the sitting and supine position to assess breast volume, ptosis grade, symmetry and skin quality. So these 4 are very important thing to plan the whole oncoplastic breast surgery complex and simple one. So these are the size of the breast. Try to measure the size of the breast. There is a way to measure. Simply ask the patient which size she is wearing. Generally it coincides with your measurement. So A cup, B cup, C cup, D cup or E cup or double D or E cup size breast. And in the lower side, see the ptosis of the breast, and it will help you in planning oncoplastic breast surgery. Mark tumor location. Marking tumor location is also very important. To how to mark it? So we divide the whole breast in a clockwise manner. So see from where this tumor is. So in this patient, it will be in 10 to 12 o'clock in the left breast. Sorry, 10 to 11 o'clock. And mark the distance from the NAC also, because if the tumor is sitting close to NAC, it's a much complex oncoplasty procedure than tumor is away from the NAC or in the periphery of the breast. And then document with the photograph. Take pre-operative photograph in almost all patients if you are planning, because you can assess the outcome post-op after surgery and after radiotherapy. So this is the patient itself. So what I have marked is the tumor area, and then I mark the 1 centimeter area what I am going to excise, and that will be the estimated size of the defect, and you can plan your surgery accordingly. So don't think for the tumor. What we excise is tumor plus 1 centimeter all around margin, and I think we never restrict to 1 centimeter. We take even 1.5 to 2 centimeter more in certain direction of the wide local excision. So think for the wholesome defect estimate for the oncoplastic breast surgery planning. What are the decision making tools? So these are the decision making tool. Breast size, what is width and cup size of the breast, then ptosis, tumor location, tumor to breast ratio. And the last is skin removal is required or not. Because if you need to remove the skin, then it's a much complex oncoplasty if you are not removing skin. So if you are not removing skin, the reconstruction, the oncoplastic reconstruction is much easier than if you are removing skin in a small ptotic breast. So what you need to see apart from this is the good mammography picture is very important. The breast density, two different type of the breast you can see in the picture. So one is the fatty breast and one is in the dense breast. And the selection of the oncoplasty technique itself is much dependent on the density of the breast and how you are doing the surgery, how much mobilization you are doing. It whole depends upon the density of the breast also. These are the microcalcification. If you feel the tumor, it's a 2 centimeter tumor, but you can see the calcification extent here. It's almost in the whole superolateral quadrant. So if you are thinking to do the breast conservation surgery, you need to excise the tumor plus microcalcification also. This is very important. In a good quality mammography, you will see the ductal extension towards NAC also. So if you are excising with the wide local excision, excise in a conical manner and go towards the nipple areola complex. Otherwise, if you will cut down here, there is a high chance of the margin positivity on the medial side and you will end up in doing multiple surgery. And the last is the speculation. So don't see the tumor only. This patient has speculation going beyond tumor 2 centimeter. So what you need to remove is not 1 centimeter margin. So if you are seeing the mammography well, you will remove at least 3 to 4 centimeter around the tumor, and you will need some form of the replacement or displacement for the oncoplastic breast surgery. So these are the, apart from the mammography, ultrasonography and MRI is also useful. So ultrasonography generally to correlate the mammographic finding with the ultrasonography, and for the nodal status, if you are thinking to do sentinel lymph node biopsy, it's very helpful in seeing that it's a benign nodes or it's a malignant node. MRI in selective setting, mainly in the high dense breast to see the other lesions, and mainly in the lobular cancer in upfront surgery. How ptosis change the surgery itself. So you can see in the first group of the patient is small breast and non-ptotic breast, and this side is the large breast in the ptotic breast. So first group of the patient, if the defect is larger, probably you will do a replacement surgery. You will put some flap, and the next group of the patient you can do the displacement or mammoplasty. And this is the way we move from the no ptosis to the ptosis. So in the no ptosis, generally the replacement are more optimal oncoplastic planning, and in the grade 3 ptosis is a more displacement with the mammoplasty procedure. How density changes your decision making, fatty breast or dense breast? So fatty breast means soft breast and generally with no support, and the dense breast is the very dense breast with the good breast support. So in the fatty breast, you can see it's a predominantly adipose tissue. You can feel it and you can see the mammography itself. And when you are doing a oncoplastic surgery in a level 1, I will not do biplanar mobilization in a fatty breast. So I will restrict on the single planar mobilization. And probably I will do more rotation type of surgery, not glandular mobilization in a fatty breast. Compared to coming to the dense breast I will not rotate too much. Dense means it's a hard. So if you want to rotate too much, you will have problem in a very tight closure. And generally the radiotherapy side effects are also different in two group of the breast. So fatty breast you will see the shrinkage, and in the tight breast you will see the fibrosis. And you need to balance your decision between the surgical choices, what you want to achieve with different type of the breast. Decision making, NSCT is also very important. You will see series of the presentation or model discussion by Dr. Sarkar, and one is by me in triple negative breast cancer. If you are seeing a 4 into 4 centimeter triple negative or HER2 positive breast cancer, try to use NSCT wisely here, reduce the tumor size and do a simple surgery. Probably you will not need a complex oncoplastic breast surgery in this setting. So type of the oncoplastic breast surgery, it's discussed a lot. Level 1 where you are removing less than 20%, very difficult to define. What is 20%, what is more than 20%? As a nutshell in a clinical, if your defect is within one quadrant, then probably you can think for a level 1, but if it is crossing a quadrant, better to think for a level 2 procedure. And as I said, displacement and replacement is the key thinking in the oncoplastic planning that what you are going to do. Are you planning to displace the breast and cover the defect, or are you planning to put some additional tissue from outside the breast, either from the lateral area or abdominal area, or the LD flap to cover the defect? And these two plannings should come into your mind when you are seeing patient in the OPD itself. So hidden scar concept, what we want to do, we want to put the ultimate scar, whatever the planning, in three regions. One is periareolar region, second is axillary region, and third is inframammary. So any planning, try to place your scar in this zone, because that will be hidden scar in the breast. So what is level 1 oncoplastic breast surgery? So glandular mobilization, you all have seen the glandular mobilization. What we do in the glandular mobilization, we mobilize the skin, do the wide local excision, and define the two breast pillar. And what technique you have seen yesterday, some of the technique are based on the glandular mobilization. So these are mainly for the dense breast, and these are mainly for the upper quadrant tumor, so superior half of the breast. So these technique are helpful for the superior half of the breast and generally in the dense breast. Second is the dermoglandular mobilization, where you are not doing skin undermining, you are mobilizing skin plus the glandular tissue both. This is mainly for the dense breast, and this is generally for the lower quadrant tumor. So we have seen the V-plasty yesterday, J-plasty and Grissotti, generally for the lower quadrant and central. Matrix we do for the upper quadrant tumor, but I will not suggest you to do the matrix, because if you have to end up doing mastectomy, generally matrix and doing mastectomy is very difficult. Level 2 oncoplasty, you have seen both the flap presentation by the Dr. Asutosh. So two different setting, but in two different type of the breast. One is the moderate size breast, 5 into 5 centimeter tumor, and the second is the large ptotic breast with a 5 into 5 centimeter tumor. And planning will be different in these two for doing an oncoplastic level 2 surgery. The first is the moderate size breast with a large defect, and second is the large breast with the large defect. And what we generally follow an algorithm which is published already in a small size breast and non-ptotic. If there is a large breast, cover it with some additional tissue by chest wall perforator flap or local flap. But if it is a large breast and ptotic breast, do the mammoplasty and cover the defect. And in a moderate size breast, you can do either of these things. So in the nutshell, a small breast with the large defect require replacement, and the large breast with the large defect require displacement or the mammoplasty procedure. This is very important. If you have digital mammography or good quality mammography, this classification came from Professor Alberto Roncati. So what it is, you see the interface here in the breast itself. So there is a breast and skin interface, and you can define your whole breast recon planning based on the breast and skin distance. So this is known as breast tissue coverage classification. And if these are the three different type of breast, and you can see the distance between the breast and skin is less than 1 centimeter in the first picture, 1 to 2 centimeter in the second picture, and more than 2 centimeter in third picture. And you choose the coverage, the breast implant coverage according to the skin flap thickness as per the Professor Roncati classification. I'm using it, it's generally helpful in your defined planning of the whole breast recon. And this I am showing with the ultrasound also. You can see the superficial fossa there, and it's very helpful for the endoscopic and robotic. When you are installing, try to see it and put the installation in that plane itself. Patient counseling is very important. If you are thinking to start, discuss with them for the need for radiotherapy and side effect, need for additional procedure if the margin is coming as positive, and these are the possible explanation you should give in the OPD. What are the common problem? Despite of all these, what you will do in the OPD, so you will end up in underestimating defect size in good number of the patient. Radiotherapy impact is very difficult to predict. Whatever you will do, some patient will have unexpected outcome. But these three things, poor patient counseling, inadequate marking, and the wrong surgical procedure selection, is generally you can develop with the training and the doing more procedure and doing under supervision. So these are some of the key problem, and you can manage with some of the tips from our side. So if you have underestimated the defect, you can add some level 2 procedure. Radiotherapy effect, anticipate it, discuss with radiotherapist, and other three are easily you can do it with the good counseling and the patient selection. This is practical clinical algorithm. So this is we follow in our OPD. So once you have confirmed the BCS, so we have lot of training. So we say that please write it, write the grade, dosage, distance. So confirm BCS candidate, assess tumor breast ratio, identify tumor location, estimate resection volume, and put in your note what procedure you are thinking will be good. It may be changed later on, and plan the symmetry procedure if required, and then do the patient counseling. So do the planning whole before counseling. Don't start juggling with the patient that what I am planning and discussing. So with this, these are the important book if you want to read. This is the Principle and Technique of Oncoplastic Breast Surgery, a very small pocket book by a Professor L.B. Tamar for the oncoplastic breast surgery. For overall breast cancer management of the surgeon, this is a guide from the guidebook from the European Professor Linda White. You can read, and these are the important author who have published a lot of article about oncoplastic breast surgery. So read about in it. It will help you in the oncoplastic breast surgery in your training acumen or in your training development. So this workshop already said by Dr. Asutosh, we are doing next year. This is third term already started. If you want, you can look upon and register. It's a comprehensive workshop. And these are the some workshop candidate itself who share the picture with us that they have done LICAP after done the workshop, have done observership and some complex oncoplastic procedure. Thank you very much, and I'm happy to answer any question.
Thank you, Sanjit. Any questions from the audience? You stunned them, Sanjit. Thank you. We call it a session then in that case, and we'll move towards the next session. Thank you.
I would like to call all the speakers on stage who have done video workshop for the photo sessions. Kindly come on the stage, please. All speakers. Dr. Ashutosh Mishra sir, Dr. Dipendra Kumar sir, Dr. Navneet Kaur, Dr. Akash Kumar Singh, Dr. Manjula Rao, and Dr. Sanjeev Agarwal. Requesting all poster presenters to present at Utsav Hall first floor. Faculty will be reaching soon to evaluate poster. I request all poster presenters to present at Utsav Hall first floor.
You have to be present for the poster, and you have to present with the judges will be around. The faculties are Dr. Namrata, Dr. Nikunj, Dr. Arunima Verma, Dr. Shrikant, Dr. Roshan BA, and Dr. Jignesh. May I request all the faculty judges to reach the Utsav Hall. It's on the first floor on the right side when you enter. So please, all the faculty judges, please reach Utsav Hall, and all the poster presenters should be there with the posters. So whenever they are being evaluated, they should be able to answer. And all the 5 posters will be selected, shortlisted, and they have to present at the time of before the valedictory function, that is around 1 p.m. And they'll be getting 5 minutes to present and 1 to 2 minutes for answering. Thank you.
Moving from the perspective of an expert to the diverse viewpoints of many, we now transition to our panel discussion. First and foremost, I may invite to the dais our chairpersons, Dr. V.P. Singh sir and Dr. Vikas Kumar sir. Ladies and gentlemen, huge round of applause for our chairpersons. I request our moderator, Dr. Ravi Roy sir. I also invite our eminent panelist, Dr. Nithya Manayat, Dr. Ashutosh Mishra, Dr. Navneet Kaur, Dr. Avinash Pandey, Dr. Reena Sinha, Dr. Pritanjali Singh, Dr. Brajendra Kumar. quickly get into the panel discussion on the topic of positive breast cancer. Over to you. I request our moderator, Dr. Dipendra Kumar Sarkar, sir, kindly take the stage.
Dr. Dipendra Kumar Sarkar, he is working as a professor and lead breast service in the Department of Surgery in IPG MER, Kolkata. I have been listening to him when I was postgraduate student in Bardhaman Medical College. And since then, I have attended so many conferences, and every conference, whenever there is a breast topic, he is one of the lead speaker. The thing that mesmerizes me is that complex things he speaks in a very simple way for everybody to understand, and he creates such an impact that you can remember those golden words all your life. Thank you, sir. Please enrich us with your wisdom, sir.
Thank you very much. It's always a pleasure to have a chairperson from my own college, Bardhaman Medical College. Actually, I was an UG student of Bardhaman Medical College. So it brings me to my alumni here, cheering my session. That's an honor and privilege. Well, I am unsure whether people would be able to see the whole screen here or not. Okay, that's, are you sure that would be the best position? Yeah. Because down the line, is it fine? I mean, you won't be able to see it, but nobody will be able to see the lower half. So I suppose, yes, that would make a bigger half. Yes. So we are here to discuss on HER2 breast cancer. Yesterday I was in Lucknow discussing locally advanced breast cancer. And the first statement that I made while we were there in that it no longer carries any meaning to discuss a panel discussion based on size estimates. It makes more sense that you talk on breast cancers based on the molecular subtype, because the treatment does not really is based presently on LABCs and EBCs. Then you have to subgroup LABCs and ABCs to make people understand. It makes more sense that you go straight as the molecular subtype. And I am going to show you the background, I mean the reason why it is so. I don't have any disclosure statement. I will take you to the background. Now I will go to the center of the stage to make you understand, well, the mic won't be available, to make you understand what is breast cancer all about. Now look at this model very carefully. Now what happens is that it's like the original human being that are called stem cells, which give birth to human beings. Whether you call it the modern male, the Homo sapiens, or the Neanderthal man, whatever it is. So the origin is a stem cell, and it gives rise to, as you see here, something called, well, the bipotent progenitors. Now these are original cells without any character. So these are characterless cells, which are the origin of the breast cells. Now then, it starts to differentiate into three forms. One is called the luminal progenitors, which in the long run will give rise to luminal cells. The second one is a myopthelial progenitor, which in the long run will give rise to myopthelial cells. That is, the myopthelial cells are cells which are squeezed between the luminal cells and the basement membrane. And the third one is a completely different site of cells which are going to give rise to a Claudine low or a complex, I mean a mixed pattern of metaplastic cancers. Now what happens in the journey is, when you are right at the beginning, these cells will express large number of HER2 new and less number as you go in this luminal series. it is going to produce large number of HER2 receptors and less number of ERs. As they continue to mature, the HER2 expression goes down and the ER receptor expression goes up. Till when you go into the completely well-formed luminal ones, then you have only ER representations without HER2. So when we look at the different subtypes, we are looking at the cancer at a subsection. Suppose you are looking at the cancer right at the beginning, then you will have huge number of HER2 expression and no expression of ER/PR. The same if the mutation occurs down the line at the Ganga near Patna, then you will have another type of expression, and when it goes down to the Sundarbans, you will have at that point the mutation will give rise to cancers which are rich in ER/PR and less in HER2. So it is not actually a different cancer, it is the spectrum at the point where you are seeing the cancer. Whereas the myopithelial progenitor cells will give rise to cancers which does not express ER/PR and HER2. They are a completely different subset of cancers. So this is the background based on which our discussion is going to happen today. The next thing you must understand before we go to the whole discussion, now these are like dish antennas on the roof of a cancer cell, and these dish antennas which are on the roof of the cancer cell alone does not work. They have to be coupled with another dish antenna to have a dimerization, and therefore it starts to get activated. So it can be HER1, HER2, HER3 or HER4, of which HER1 is the EGFR. So you can have a combination of HER1 and HER2 giving rise to dimerization. You can have a combination of HER2 and HER3 giving rise to dimerization, but these are all heterodimerization. But when an HER2 and HER2 combines, it is a homodimerization. So once this coupling happens, the next thing is the pathway is stimulated. And there are two different pathways, again for training to understand, because the whole concept of therapeutics depends on this. Now one pathway is called the RAS and ARC pathway. Now this will actually go down to, provoke cell proliferation. On the other side there is a PIK3CA, AKT and mTOR pathway. They also provoke proliferation. And down the HER2 on the roof, just beneath the roof, there is a receptor which is called tyrosine kinase receptor. You can modulate the cancer at that level also. So now you can modulate the cancer at the dish antenna level. You can modulate the cancer beneath the dish antenna as the line goes into the room or into the house, and finally you can modulate it down at your TV set. So at different levels you can modulate, and therefore you must know this. And these are examples of where exactly the cancers can be modulated. So therefore, our first learning objective is defining what is an HER2 cancer. I have an illustrious pathologist, madam, with me. Madam, if you could tell us to the trainees in a very simple way, what is an HER2 enriched cancer? And the second question is, how do you score an HER2 expression?
HER2 enriched cancers are a molecular group of.
Madam, it's fine.
It is a group of molecular classification. Is a group. It is HER2 enriched type. In this, the HER2 is positive, and the main thing about this group is that this is very aggressive, but there are now it is of good, seen that this has got very good response to the newer ADCs. So this is a special group type of HER2 positive, which is a molecular type, and it constitutes about 20% of the.
So, madam, the next question to you is, how do you, tell it's positive, and how do you score in HER2/neu?
HER2 scoring is done from score 0 to 3+. Score 0 constitute that there is no membrane staining at all of the tumor cells, or less than 10% of the tumor cells shows faint and incomplete positivity. Then comes HER2 1+, in which greater than 10% of the tumor cells shows weak or faint positivity. Score 2+ is greater than 10% of the tumor cells are complete, but shows weak to moderate positivity. In score 2+, we go for reflex testing, and if this reflex testing or gene amplification is positive, it comes positive, then it is considered as HER2 positive. Then comes the score 3, in which greater than 10% of the tumor cells shows complete, intense, and circumferential positivity. And this is considered as HER2 positive.
Okay. So, you know, for trainees who are sitting here, we are used to defining HER2/neu cancers as HER2/neu positive or HER2/neu negative. If it is 3+, it is positive. It is less than 3+, there is a gray zone. Madam, if there is a gray zone, what investigation apart from IHC will you use? I mean, it's a 2+ lesion in IHC. Would you agree to this, or you would like to go ahead with some other investigations?
No, we will reflex it to ISH, and if it is negative, then it is considered as negative, and if or low positive.
Okay, so you know, so what madam suggests is that if it is FISH negative, then it's negative. Now I go to the next slide. There had been a sea change in understanding. We were sort of yes/no types. Now that you have this in front of you, madam, that was the new definition. How would you tell it to the trainees? What do you understand by 1+, 2+ in the era of current evidences?
Now the first score 0 has been again subdivided as 0 and 0+. Score 0 or null type, in that there is no membrane positivity. None of the cells take membrane positivity. Then comes 0+ or ultra low, in which even less than 10% of the tumor cells shows weak positivity, then they are considered as ultra low. Then the score 1+, which was more than 10% but weak, along with score 2+, which is ISH negative, is considered as low HER2 positive.
Thank you, madam. So you understand, trainees, now we have redefined it from a concept of yes/no to going into the gray zones and telling there are a subset which are expressing, and we thought it is just triple negative breast cancer. But the current concept is these are also stamped as HER2/neu positive, but they are low positive. And towards the discussion, we will understand what is the implication of that. Now I come to the second learning objective. What is the impact of neoadjuvant systemic therapy in breast cancer, particularly on HER2/neu enriched cancer? I will start with madam, Navneet madam. Well, this is a 52 years female presenting with a clinically 3x3 centimeter cup-C breast with a radiology which shows 28 millimeter by 30 millimeter N0 IDC grade 2 HER2/neu 3+, ERPR negative, Chi67 35%. Now the patient wants a breast conservation. Would you go ahead with breast conservation in this patient? Madam, it's not working.
For breast conservation.
Given the fact, I will go to Ashutosh. Now, Ashutosh, given the fact that this is an HER2 enriched cancer and the size is 28 millimeter by 30 millimeter, let's go to the next slide. And this is the radiology. Would you go ahead with breast upfront surgery, or you wish to have a neoadjuvant systemic therapy?
Yeah, so basically in TNBC and HER2 enriched, so now we have the data that there is improvement in overall survival and there is less invasive DFS, improved IDFS. So particularly more than 2 centimeter size tumor, most of the time we are going for neoadjuvant systemic therapy. It's usually followed at most of the places. Tumor less than 1 centimeter, we can directly go for the surgery, then we can plan for the adjuvant systemic therapy on the basis of histopathology report. 1 to 2 centimeter, it's a bit of a gray zone in different multidisciplinary settings, somewhere where medical oncologists are too aggressive, then more than 1 centimeter, they start giving systemic therapy. So more than 2 centimeter definitely for systemic therapy, neoadjuvant systemic therapy, less than 1 centimeter upfront surgery. 1 to 2 centimeter is a gray zone as what we are practicing.
Madam, once again getting back to you, would you agree to this statement if Ashutosh makes this statement in MDT to go ahead with a neoadjuvant systemic therapy in a 28 millimeter breast cancer, HER2 breast cancer?
Yeah, I think that's the current practice. So patients more than 2 centimeters, especially HER2 positive and triple negative, and even as he said T1C, that is 1 to 2 centimeters, especially for triple negative, again upfront chemo is being recommended as the better modality of managing these patients.
Okay, madam, if you could pass on the mic to Dr. Azhar. Well, Dr. Azhar, now, if the patient would have, oh, he's, okay, you are here.
There is almost 67% PCR rates in neoadjuvant systemic therapy reported. So more than 2 centimeter tumors, HER2 positive or definitely triple negative, I would surely recommend neoadjuvant systemic therapy.
Now, if the patient would have wanted mastectomy, it's a perfectly mastectable condition, would you still then recommend neoadjuvant systemic therapy?
Yes, that will make the treatment more tailor-made in prognostication also.
Okay, so trainees, you need to take this point very strongly that in HER2 enriched cancer, 2 centimeter is the cutoff, whereas in luminal you can play it at 5 centimeter. Therefore, the wall that we call locally advanced at 5 centimeter and more does not any longer holds true. So in 2 centimeter you go ahead with neoadjuvant systemic therapy. Now, I suppose there's a gentleman who is a radiologist. We didn't get into, yes, sir. Now, we have decided to go ahead with neoadjuvant systemic therapy. What neoadjuvant systemic therapy would you normally prefer in your clinical practice?
Asking to me, I'm a medical oncologist. So we can, for this patient, we can either give a weekly taxanes, carboplatin, trastuzumab, and bortezumab.
I would first go to the radiology part. Sir, my question is, what radiology, because I know he is going to give neoadjuvant systemic therapy and once again send the back patient to you. So what radiology in terms of diagnostic accuracy as well as in terms of assessing the residual disease you would prefer?
Assessment of residual disease, my answer will be two. One is the academic answer, which is a contrast enhanced diffusion weighted MRI, which is accurate and has a good correlation with pathological complete response. But as we practice here, I would say it's a multimodality approach where I find ultrasound very useful, sometimes coupled with mammograms, and a clinical breast examination would be probably adequate if you are not planning to totally get out of surgery without surgery. So it helps in response assessment as well as the change in the NAT, whatever they are thinking. if
So
possible.
you are possibly in doubt whether your practice is appropriate or not. Would you like to switch over to MRI completely?
Not at all.
Not at all.
I'm not in doubt at all. Because in the part of country which we live, that's the most appropriate.
Yes. So you strongly believe that MRI should not be the standard of care in every single patient?
Yeah, it's right statement. In every single patient, it is not the standard of care. I understand that if you are not planning to do surgery at all in this patient, if there is a complete response, then MRI is appropriate, or where the patients can afford.
We will come to that debate last in the line, whether we can be not holding a Surgicon in 2030. That's the last part of the debate. But as of now, you are not recommending routinely MRI.
Right.
That's it. Okay.
Right.
So can I have, Madam, you can take this question. Now, are you happy with this? Are you truly in favor that MRI should not be done routinely?
So it should be offered to the patients routinely, because that's the best, it has the best sensitivity and specificity to observe whether there's residual disease or not left behind. But of course, as Sir was saying, that most of the patients are not affording, and we can also live in a resource limited state, so we cannot offer it to everyone. So in that case, mammography
Madam,
can be offered.
suppose Ayushman starts covering MRI in every single patient. Would you then advocate MRI for every single patient?
It's not just the resource, I mean the monetary resource that should be available. The time on the machine is also important. So if the machine is free, definitely I will advocate that.
If the machine is free, I go to Dr. Rishi. Would you, if you are asked to plan the breast cancer guideline by the ministry, would you put in MRI as the tool routinely?
I'll just start by saying that it is a decision which is related not only to resource, it's also about pragmatism. I was speaking to Dr. Kelly Hunt, MD Anderson, just casual discussion about how do we monitor response to neoadjuvant. And she said, that's America, MD Anderson. She said, no, we don't do MRI on a routine basis. We are selective. We are also limited in resources. So I think it is good to have MRI if it is a very dense breast and you want a good definition. But in a lucent breast like this, one can easily argue that what is the value? So I think it is good to work as a team, good to take all the other factors into consideration, not only the resource. That's my answer.
Okay, thank you. So the point for the trainees is, yes, sir.
Do we actually all the time assess the radiological response? Because all the way we are definitely going to address for the pathological response.
I mean, pathological response would come after the surgery.
Yes.
But right when you are taking a decision whether this patient would be offered a breast conservation or not, then you have to rely on a radiology. And that's the reason most of the time you can rely on the standard mammogram and ultrasound. Once in a while, as Dr. Rishi rightly mentioned, there is a subset of patients, mostly dense breast patients, in which MRI should be used based on the discussion MDT, but routine does not actually. Again, yes.
So most of the time the clinical examination and routine radiological examination gives us an idea whether we can proceed with breast conserving surgery after downsizing the tumor. So MRI scan is not at all routinely needed.
So that's the point. If there are trainees here, they need to take home that MRI scan is not the standard of care. When will you place a marker? May I go to Madam, please? When will you, right at the beginning?
Sir, before that, for response assessment, whatsoever investigation we have gone for the baseline, that should be assessed by the same investigation.
Exactly.
That's also important.
Yes. So, Madam, my question is, when will you place the marker? Right at the time when you have done a core biopsy, or you give 1 cycle or 2 cycle and then place in a marker?
No, the marker is placed right at the beginning.
even
right
before
at the
a single
beginning.
cycle
If
of
there is any
chemotherapy.
devil's advocate on that side
No.
who would like to place it after 1 or 2 cycles?
So basically, these tumors respond very fast to the neoadjuvant systemic therapy. So sometimes there might be patchy response. So we may misplace the center of the tumor if we are putting upfront. But in routine practice, we are putting it upfront. Otherwise, one cycle after one cycle, it's advised as
Okay.
subset.
So yes, if it's a bigger size lesion, it makes sense that you give 1 or 2 cycles and then send it to sir to put in a, because the epicenter might change after 1 or 2 cycles. Okay, sir, would you like to place in a marker, or you would want your surgical colleagues to put in a marker?
I place tissue markers myself under ultrasound guidance, and if required, it can be placed under stereotactic guidance as well if the lesion is only seen on mammography. So this is done usually in the same setting when we do biopsy, because that escapes unnecessary another procedure and scar. So that's probably the standard of care right now, where we place a tissue marker there.
Okay, I go to my medical oncology colleague. Now, how many cycles are you going to use in this gentleman before we would proceed for surgery?
Yeah, for this lady, I like to go with complete 6 cycles of neoadjuvant chemotherapy, either in a weekly or a 3-weekly pattern. I generally give a 3-weekly pattern of taxanes, carboplatin, trastuzumab, and pertuzumab, all 4. Now, there is a recent data which has been published few weeks back where omission of carboplatin, especially in stage 1 and stage 2, has not led to any inferiority in the pathological CR rates. But for now, in general, TCHP is the standard of care every 3 weeks for 6 cycles and then surgical intervention.
Okay, so again, trainees to note, 6 cycle is the standard of care. Now, this is the reason why people are so fanatic, and we are probably escalating treatment and de-escalating surgery. Well, this is the landmark trial published in Lancet, which showed that in triple negative and HER2 enriched cancer, if you are able to achieve complete pathological response in the postoperative histopathology, that means the chances of the patient living more is higher. Now I go to this patient. Now this is the patient, again to my medical oncology colleague. We are in an MDT. Now this is the histopathology. I have given you a gray zone. It's a 6 millimeter residual cancer burden. Now what is your choice at this particular point of time?
So this patient has received 6 cycles of neoadjuvant combination of trastuzumab and pertuzumab and still has a residual invasive disease. Okay, so there are 2 options in this cohort of patients. Traditionally, we used to switch to TDM1, which is an adjuvant chemotherapy and targeted therapy combined for 14 cycles. And now, a couple of weeks back, a new study has been published, Destiny 5. Which
we will go to the destinies later on. So, in 6 millimeter, again, I may be the devil's advocate, I may be proven wrong. If I believe, if there is robust evidence that if it's some very small microscopic residue, can I continue with dual blockers, or I have to shift mandatorily to TDM1?
So if it is not PT0, if it is not PN0, you have to switch to TDM1.
Okay, so well, that's a gray zone. We can debate on this, but if you look at the standard answers that you are going to give in your exams, then you have to switch over to TDM1. Yes. The question he asks you, if there is DCIS only.
So we'll continue, we'll take it as a, so PT0, TIS and DCIS are taken as a bunch together, and will, if take it as a PT0, DCIS, will not switch to TDM1, will continue the conventional therapy with them.
Now this is all based on this particular trial that was published in AIIMS. Now again, I will go to Ashutosh. Now Ashutosh, would you like to explain this particular algorithm to the trainees very briefly in say 1 minute time so that they can take it forward? What should be the current standard of care for HER2 enriched cancer?
So any HER2 enriched tumor less than 1 centimeter, directly go for the surgery. First, more than 2 centimeter, neoadjuvant systemic therapy. 1 to 2 centimeter, it's your MDT choice. Post-surgery, if there are any residual disease, then you need to switch the anti-HER2 therapy. If you have given the Herceptin pertuzumab in the beginning, then you need to switch to TDM1. And if there is complete pathological response, then continue the same treatment for next 1 year, complete the 14 cycles up till 1 year. And if you have gone for the upfront surgery and node positive, then you can directly go for dual targeted therapy on the basis of the high risk factor. And if there is PN0, then single trastuzumab anti-HER2 agent or 2 centimeter size.
Thank you. Thank you for explaining this. Now again, I go to my medical oncology colleague. Well, now there are trainees, and I mean, Dr. Navneet, can you take the initial question? Then I go to the rapid fire to him. Now, trainees, they have been exposed to a new term called ADC. What is ADC?
So it's an antibody and an anti-cancer agent conjugate. It uses the antibody tying to the cancer cell as the kind of a transport mechanism. So the anti-cancer drug is delivered into the cell and hence induce a cell killing. So it is increasing the toxicity to the cell by delivering an anti-cancer agent through a kind of a carrier, where the monoclonal antibody is the carrier.
So you know that the dish antenna is being targeted, and you go into the antenna and pass on the chemotherapy inside, and then in the lysosomal level it breaks down, it liberates the chemotherapeutic agent which causes the inhibition or I mean the cell replication. Now I go to the third learning objective, the impact that ADC made in breast cancer, particularly in HER2 enriched cancer. Now the same lady now comes back after 21 months, and now she has multiple lung mets. The patient has been used on trastuzumab and pertuzumab and has been used on TDM1. Now we are in the MDT, again to my medical oncologist colleague. Now in this particular scenario, what would be your next choice? Yes.
So TDX2 will be good here, but having said that, the patient has multiple lung mets, and TDX is known to cause interstitial lung disease in about 10% of patients. But TDX also works very well in HER2/1 plus patients as well. So, but I would still would like to undergo this patient a rebiopsy and a FISH test, even if it is FISH negative.
So that's the rebiopsy report.
So
so it's
even
1
if
plus. It has downgraded now.
So still TDX can be used in these patients, and I believe she will be having a very good, meaningful response to that.
Okay. So, you know, again for trainees, what is being suggested that in particular this scenario, you can want TDX1. So these are the 4 choices. So, I mean, you would go to TDX1.
Yeah, number 4.
Now, I go to this trial conclusion. Now, go to this conclusion, you will understand. If I ask you to kindly let people know what exactly the trial conclusions are, then I will be really enchanted. If you could take this statement.
Yeah, so conventionally, people used to use normal chemotherapies, including capecitabine or pemetrexate or gemcitabine, compared to a physician choice alternative of patients who have progressed on TDM1 as well as on pertuzumab and trastuzumab. Use of TDXD in patients even having a 1 plus HER2 positivity increase the progression-free survival by double, that is about 10 months compared to 5 months.
And you know, in the survival also, it's 16 months to almost close to 24 months. So that makes sense. There is a good amount of evidence to, one must understand, with the hazard ratio say 0.51 and 0.64, that makes good sense that in pre-treated patients you can shift to TDX1. Now I want again, I mean, you know, I am asking you these questions because we are really worried that after some time only these panels will be done by medical oncologists and surgeon will be left with nothing but an adjuvant therapist. And never mind, because that's the reason why I am asking these questions multiple times to my medical oncology colleague. Well, these are the two different diagrams. Why did TDX1 did better than TDM1?
So it has a better affinity, it has a better perisomal and endosomal capacity to penetrate inside the cell. And third thing is the efflux of TDXD is very, very less compared to TDM1. So that makes the bioavailability much, much higher of TDX2 compared to TDM1. Thus it happens to be a higher value and higher response rates and leads to a meaningful PFS and OS.
Okay, now to make things a bit clearer to my trainees, I will add few more sentences to this. Now, what we told is you get stuck to the dish antenna, pass on the chemotherapy inside, it goes into the lysozyme, breaks down and then destroys the cell replication process. That's how TDM1 acts. Now TDX1, now if you look at TDM1, the ratio of drug and the antibody is 3.5:1. Whereas in TDX1, it is 8:1. That means for one antibody, there are 8 different deruxtecan which is being attached. So number one, there is, so even if it's HER2/neu low, it is likely to act better. Number two, a very important phenomenon occurs that is called a bystander effect. A bystander or a cleavage effect is when it gets inside the cell and in the lysozyme it breaks down, it lowers the pH of the cell. What it does now is it destroys the surrounding cancer cells as well. So therefore, TDX1 is likely to work better than TDM1. Now, if this is a patient, a 48 years female, a 34 millimeter, if we try to extrapolate the same data for an HER2/neu 2+, a low positive, again to Ashutosh. Now, if this is the patient, is there any evidence that we go straight with a neoadjuvant systemic therapy based on an HER2/neu enriched category? It is a 2+ FISH negative.
So basically density 5 trial they have introducing role of anti-HER2/neu therapy in early breast cancers. So although it was presented in 2025 ESMO, and I'm not sure whether it's been taken properly by all the guidelines or not, but it's still in low HER2/neu, now there is the role of neoadjuvant systemic therapy.
Okay, so anybody here would like to believe that in an HER2/neu enriched cancer, we were talking about HER2/neu 3+, now it's a 2+ disease right at the beginning. Does that make sense? We should switch over to TDX1 by any means. Anybody who would like to take this question? Well, let me go to the evidences. Now, the question is whether you should consider this at this point of time as triple negative, or you should consider this at this point as HER2/neu enriched. It's a low disease. So if you believe it's a positive disease, then you have to go with dual blocker or TDX1. If it's a triple negative, then you have to go with triple negative. Now let's look at the evidence. Now this is the evidence. Again, for trainees to understand, as of now, HER2/neu low disease, you should not be using TDX1 as the primary neoadjuvant systemic therapy. It is for metastatic disease. It is not for primary ones. But if you have gone ahead with a 3+ disease, and in the 3+ disease you have come to a residual cancer burden, Then I will take you the trial conclusions. Now you have on one side a neoadjuvant trastuzumab TDX1 versus TDM1 in the post-adjuvant setting. It's a 3+ disease. Now there is a residual cancer burden. Then instead of TDM1, you can shift to TDX1. But HER2/neu low should not be treated as HER2/neu positive as in upfront cases. That's the conclusion of this slide. Now suppose, well, I come to the same patient who has same disease. So the conclusion is, will you shift to TDX? If it is a 3+ disease, the answer is yes. You can shift to TDX. But if it's a 2+ disease, then you should not be considering it primarily as an HER2/neu enriched disease as of now. But the evidences probably will go on the opposite side. Now I come to the 5th learning objective. What makes HER2/neu most dangerous? It's because its signaling pathways are such that it can develop more of brain metastases. Now if you look at this, gentlemen, again I am going back to my medical oncologist. And of course, did I have one radiation oncologist in our team? Yes, madam. I have got 3 choices for you. One is stereotactic radiotherapy. The second is shifting to tucatinib. That's again a tyrosine kinase inhibitor. And finally, Enhertu or TDX1. Madam, it's a debate between you and sir. What would you choose?
So this patient has 2 or 3 lesions in the brain, as I can see, and one of the lesions is quite large. So I would not do upfront SRT in that. Maybe we would, if there's any mass effect, then maybe it can be taken out by surgery first, and then we could do SRT to the smaller lesions. Otherwise, even the 2 drugs that are there, the TDX as well as the tucatinib, they both cross the blood-brain barrier and they are effective. So it depends on how the patient is faring. I mean, the GC of the patient, if the GC is okay and the patient is not compromised at that point of time, I might go forward with drugs. But if the GC is low and there is mass effect, then of course surgery followed by SRT.
Okay. So I go to again to you, you know.
We have such patients currently with us. So I have 5 patients. 2 of them had undergone radiation and they are on tucatinib. 3 of them had non-symptomatic brain mets, incidentally diagnosed. And 3 of them started on tucatinib. After 4 months, 1 had to undergo radiation. Another 2 are continuing tucatinib very well. I personally don't have any experience with TDXD in metastatic brain cancers with HER2/neu positivity, but that's also happens to be an excellent choice. In short, I would like to summarize, if the brain mets is there without much symptoms or minimal symptoms or no symptoms, then systemic therapy either with tucatinib, capecitabine, trastuzumab or TDXD will be an option. But if the patient has symptomatic brain mets, then radiation plus minus SRS followed by systemic therapy happens to be best option otherwise.
Okay. Sir, you picked up the mic. Would you like to have
just a question. So, instead of these 3 lesions, suppose there are 5 or 6, would the management will be the same from your side?
Again, madam.
We can do SRT in 5 or 6 lesions as well, and that would be my way forward, because we would like to, we think of the cognitive decline of the patient as well, and we would want to spare as much as normal brain as possible, because that is the way ahead these days. With hippocampal sparing also we can do the radiation.
I come to the last one. Well, it's a very nervous entity for me. I am on the verge of some trials which is trying to put us out into the registration desk only. Now I'm going to take you through the results. Now we have a very happy group from the Western European group who told, yes, it's not the time to omit surgery. But here we have a gentleman who is, in our terms, bibishon. I mean, he happens to be a surgeon who is fighting to put surgery into oblivion. Now, what they are doing is they are putting in, particularly for HER2/neu enriched as well as triple negative breast cancers, neoadjuvant chemotherapy, not allowing complete radiological response to happen. Once there is a residue which can be seen, at that point they are doing VAP or taking out vacuum assisted tissues, 6 such, and if they find it's negative, there is no such, they are omitting surgery. So if that is the cause, now let's see what happened. The publication that came couple of years back, at the end of 26 months, no recurrence. But the sad news for us is at the end of 55 months, in those subset of patients, close to 31, where neoadjuvant therapy was associated with complete response preoperatively, when surgery was omitted, the recurrence rate is 0. So I come to the last debate. Well, Ashutosh, Ashutosh, madam is a strong surgeon. Madam, would you agree to this statement, yes or no?
I think it's too premature to rely on this statement. So in 5 years, experience only on 50 patients with some long-term follow-up. And 5 years, 10 years down the line, there may be a recurrence. So as of now, I don't think we can think of no surgery as an option. Let the more data come in, and then let's be convinced enough that this is safe. As of now, I would say it's not the opportunity to the surgeon, and they are not always feeling in the category of HER2 3+. They may be HER2 2+, where HR positive, they don't respond so well. So first of all, just 20-30 patients who can be in the category of having only HER2 expression that's strongly positive, which can be responding so well to neoadjuvant chemotherapy that tumor completely disappears. But then we still have to have more trials and more data.
Okay. Madam is picking up the mic, and I am sure you are
I'm a surgeon. Yes.
good.
Yeah.
I am with you.
Yeah.
Now
So,
you can shout.
so if you actually, it's very, like Dr. Navneet said, it's very premature. This was only 50 patients we had. And even if you look at the micro analysis that they had, the vacuum-assisted biopsy, the false negative rates were very high. They were close to around 45-49%, if I'm not wrong. So with that high of false negative rate, how are we going to rely on the vacuum-assisted biopsy saying that there is a PCR? So I think definitely it's too premature. And if you look at the pathological complete response in the micro-analysis, in the micro itself, it was not as 90 or close to 100%. It was still only around 65 to 75%. So I think we are not going to be written off so fast.
Madam, if I am the devils, I am on minority side here. Now, micro content even luminal cancers.
Yes.
MD Anderson, luminal is out, only HER2 and TNBC. Would you still agree to your statement?
Yes, I think with the biopsies, the vacuum-assisted biopsies, earlier you're completely changing the whole oncological principle. So earlier we were of the thing that, when you're excising a tumor, you have to have no tumor at the margin, all of that. Here you're taking random biopsies from the area and saying for sure that you're not going to have any residual microscopic disease. And with showing a false negative rate of as high as 45 to 50%, I don't think we'll agree on that.
I give you 15 seconds. No, okay, you want to take the... Are you going to push this gentleman out of the stage? Okay, last...
For me?
Yes. Would you hold with a surgeon called Henry Kruger?
It's a very crucial question because my employer happens to be a surgeon.
Oh, great.
So there's a conflict of interest here. But so if we have a very good surrogate to measure the pathological CR rates without surgery, for example, in this case, a vacuum-assisted core biopsy, it gives a very meaningful result if there is a no recurrence at the end of 2 to 3 years of follow-up. There will be time coming very soon that in this cohort of patients who have a surrogate pathological CR by a vacuum-guided core biopsy showing no cancer residual disease, we can closely observe the patient without a surgery.
Do I take the permission of your employer to put your mics off?
Yes.
I come to the last presentation now. Ladies and gentlemen, this is the picture of two dons in Bollywood. This gentleman is Amitabh Bachchan, and that gentleman is Rajesh Khanna. If you look at Anand, both of them were brilliant, but we thought Rajesh Khanna was outstanding. But This gentleman went on changing himself multiple times, and this gentleman refused to change himself, and therefore this is a picture later on. Look at this gentleman who has changed himself and made himself relevant in today's era. Today's kids also line up to see a movie by Amitabh Bachchan, and we used to line up as kids to see Amitabh Bachchan. That's the reason I put this one, to make you understand change is permanent. Thank you very much.
I just wanted to make one comment. I'm sure we are run out of time. Just a remark. We also have to factor in the systemic toxicity of these drugs, right? And it's not that only surgeons are looking at it, even the medical oncologists are looking at it. Because EGFR is expressed at so many other places.
I take your point, madam. As we were coming back,
I'm
we were
talking to
discussing.
the train. I'm talking about the train trial, which is the trial phase 2 trial, which has been recently published, train 3, which talks about de-escalating the treatment to reduce the toxicity. So they are looking at MRI and to kind of, curtail the number of cycles. So instead of 4 to 6, they say that after 2 or 3 cycles also, if there is a PAT-CR, then the systemic targeted therapy may not continue. So
Okay.
this is just
So it's a fight between interstitial lung disease and lymphedema.
Yeah.
Thank you very much.
So thank you very much, sir. It was definitely HER2 enriched and knowledge enriched as well. So let us pose for the photograph and finish the panel because we are running out of time. Thank you.
The energy in this room is incredible. It's time to take photos. And now moving to the next session, much anticipated guest lecture session of ABSI SKILLCON 2026. It's my honor to invite on stage our guest speaker. Ladies and gentlemen, put your hands together and please welcome on stage Dr. Navneet Kaur. थोड़ी तालियां होती रहनी चाहिए. Thank you everyone. Thank you very much. And I may invite to the dais our chairpersons, Dr. Rishikesh Parmeshwar sir, Dr. Jitendra Tolwani sir, Dr. Rinku Kumari. Over to you, ma'am.
Thank you so much. So I'll be talking about adoption of oncoplastic surgery in Indian landscape and the future directions. And I think in the process, I will talk about the evolution of oncoplastic breast surgery, how it has evolved over the last 2.5 decades, and also my journey through the last 2.5 decades of oncoplastic surgery in India. When I started my career as a assistant professor in a medical college in Delhi, I used to see a lot of breast patients because they will automatically prefer a female surgeon to have a look at them. So that became my area, that became the starting point. I realized that I have to learn extra than just the mastectomies. So for that, I was looking for options to upgrade skills and look at breast reconstruction. And I applied to a couple of centers and eventually landed up at European Institute of Oncology, Milan, for our training in new techniques in breast reconstruction in 2003. At that point of time, oncoplastic breast surgery was just about 5-6 years old. And Professor P.T., who was my mentor, was one of the people, along with Professor Aldrich, who kind of gave the concept of oncoplastic breast surgery. And from there, in 2003, I took my training on oncoplastic breast surgery, which was essentially a kind of a reduction mammoplasty technique at that point of time. And since then, in last 20 plus years, how it has evolved and how it has been kind of accepted in the Indian practice by surgeons as well as by the population at large. This is kind of a journey that I'll share in this presentation, and from now, where do we go forwards? So we have seen in the last 1.5 days of deliberations, rather 2 days of deliberation, how evolution has happened from radical mastectomy to breast conservation, to oncoplastic surgery, and the constant debate and the constant threat that we may be extinct in not so distant a future. By the precision medicine we heard yesterday and all the non-invasive techniques we ourselves are propagating. And I remember Professor Henry, who has published result on no surgery, came to one of our ABSI cons in 2013 at Chandigarh. And at that time he presented his work on circulating tumor cells. So we know the definition that it is surgery in which the tumor excision is combined with plastic surgical techniques to give an outcome which is cosmetically beautiful, which is called as oncoplastic breast surgery. And the definition debate continues whether we should we should also include mastectomy as oncoplastic breast surgery. And if I look at the guidelines by UK people, they take it as partial, they include mastectomy as part of OPBS, and they have kind of something called oncoplastic mastectomy. Whereas in American guidelines, they only talk about partial mastectomy defects being covered by local techniques. So the need for plastic integration into surgical excision came with the results which were seen in some locations when the only BCS was done, especially the lower pole or the central locations or the upper pole, which were the areas which will give a poor result with a simple cosmetic technique. And the first paper that kind of brought into focus, and Professor Aldrich, who is considered the father of oncoplastic surgery, was a close friend to Professor Pitti, who was my mentor, and one being a German and other being a French surgeon. They conceptualized, but the title was given by Professor Aldrich, so he gets more recognition for his contribution to the term. The paper was about tumor-specific immediate reconstruction in breast cancer patients. So they said that if at the time of surgery, a plastic surgeon is involved in design planning, then the results of simple mastectomy can be enhanced. And that is the starting point of oncoplastic breast surgery, and the paper came out, I think, in 1994. The initial results, initial kind of techniques were totally based on reduction mammoplasty. If we have a large breast, and if we are going to reduce by taking out, say, some 1.5 kg of tissue from each breast, in that kind of a tissue, if the tumor is within that tissue, then obviously we end up with a reduction as well as a tumor out from the cancer treatment point of view. So most of the initial papers and techniques were about reduction mammoplasty techniques, and post the Aldrich paper, Professor Krishna Klo, who's a half Indian and a French, was the one who took up the the moment in his hands, and he did then a lot of work in next 10 years, talked about the classification, the quadrant-wise application, gave us the different levels of oncoplasty, which we understood as level 1 and level 2 based on the complexity. And along with these descriptions came the various incisions that can be planned at the time of lumpectomy, so that we are able to integrate plastic and oncological procedures at the same time. So for, I think, good 10 years, 2005 I learned, I would say, 1995 till 2010, more or less we were talking about the displacement techniques. If they were small displacements, they were level 1. Like these, they just required a closure of the defect, some kind of a re-centralization of the nipple areolar complex. And these were all level 1 techniques in which not much mobilization was required. And this one I showed just some time back, the video also. And then they were a little more complex, which required more mobilization, consideration of a pedicle which will supply the nipple areolar complex, like superior pedicle, inferior pedicles, superomedial and all that. They were the type 2 reduction mammoplasties which were being practiced. And they were generally combined with a contralateral symmetrization to achieve the optimum results, because just reducing one breast and keeping the other large ptotic breast was not, again, the outcome patients might be wanting. And many of these modifications. And were they safe? Yes, there was enough data, and this was one of the papers I wrote when I was in Milan about the margins. So one of the very early studies when we looked at the length of the margins which could be achieved by oncoplastic breast surgery, and hence it should have been safer. Later on, even the margins have been redefined, and now wider margins are not required anymore. What we talk about is just no tumor on the cell margin. But yes, this was the early work, and there was a long-term follow-up also, which was subsequently published. volume replacement became the need when the breast was small and there was not enough tissue to reduce. And latissimus dorsi, mini flap, and the local fasciocutaneous flaps or transposition flaps were the norm before that also. But the real game changer was description of perforator-based flaps, and that was Professor Hamdi in 2004 that he came out with the perforator-based local flaps for volume replacement. And since then, the techniques have been, every day a new method was described of perforator-based flaps. So these perforators, again, have been shown multiple times. I'm just kind of giving a recap of what has happened in the field of oncoplastic breast surgery over the last 2 decades. So these perforators come from many vessels which supply the breast tissue and also the tissue around the breast. So there's a lot of fat which is in the inframammary fold, lateral chest wall, which can be kind of mobilized on a perforator which is perfusing that area, and it can be used to fill up the gap. And we heard about LICAP, TDAP, MICAP, all kind of perforators. So this is a patient with a small breast. She wants a conservation. There is no scope to reduce the breast. So we have to replace. One option could be latissimus dorsi. That is too extensive and morbid, and I think LD should be reserved for whole breast reconstructions. So this was one of the easy ways to use a perforator-based flap and kind of. So these flaps gave us this liberty to utilize the tissue without sacrifice of the skin most of the time, but skin could be used if required, so that we have a skin envelope which is intact and the defect which is filled by the tissue, and a result as good looking as that. So this is another patient, triple negative, had a very large tumor. Even post chemo, she had residual tumor size of this. She had a large breast. So LICAP with TDAP was combined. She had PAT-CR on histopathology, so that's a good thing for her. So volume displacement based on reduction techniques, followed by replacement. And I think this replacement paradigm is also evolving every day. So we have now dual flaps, we have trench flaps and ST caps, and so more than one kind of perforator-based flap can be combined. And now recently there is a video uploaded by Dr. Amit and other reports also, when whole breast reconstruction is done with just perforator flaps, perforator-based flaps to reconstruct the whole breast with some kind of a dermal sling. So indications and utilization of replacement oncoplasty is being kind of expanding every day. And then came the concept of extreme oncoplasty. This was, I think, 2015. Again from Europe, a paper. I think UK suffers more from regulations. European surgeons are able to experiment more. So they did some surgeries in patients who were candidates for, so far, contraindications for breast conservation. So if it is a multicentric tumor, that too, they said, can be offered a conservation, provided we are, of course, achieving the oncological safety margins and achieving a result which is cosmetically superior. So this extreme oncoplasty is indicated for extensive macrocalcifications, locally advanced breast carcinomas, with partial response, small tumor. So I can show some papers and the techniques which they have shared for expanding the indications of oncoplasty, even in patients who would otherwise definitely go for a mastectomy. And so they can use 2 pedicles. It need not be only 1 pedicle and a glandular mobilization. People understand now the vascular codes of the breast better. Even the breast anatomy has been redefined by the oncoplastic surgeons by description of more Wuringer septum and other things. So based on that, within the breast, you can use tissues and kind of move it to fill up defects in different quadrants. So this can be a double pedicle technique. And this is another one which shows there is a extensive multicentric lesion which has been wire localized by 4 or 5 wires, and then the design has been fashioned in a way that the entire tumor specimen is out and a cosmetic result. Is it safe or not? It is too early to say that, because extreme oncoplasty has been around, I would say, now 10 years. We haven't had very big numbers because very few patients will qualify to be the candidates, and very few surgeons have the expertise to offer this kind of a surgery. But extreme oncoplasty definitely is another dimension which has been introduced and will be tested in times to come. Efficacy and safety of these procedures have been definitely constantly monitored, tested, and the data will have us believe that they are as safe as breast conservation surgery. Now oncoplasty is even part of NCCN guidelines, and in fact NCCN now says for early breast cancers treatment is more of a breast conservation. Mastectomy should be reserved only for certain indications, and then oncoplasty reconstruction whenever feasible, possible, should be offered to the patients for managing their cancers. And then there are different guidelines by different societies. This one is from UK. And then we have American surgeons who have come up with their guidelines. ABSI so far has not done that. We are only publishing consensus statements, but I hope in few years down the line we should be also coming out with ABSI guidelines, and which should be more resource satisfied and kind of more monitored and regulated. So how has oncoplastic surgery been adopted in the Indian landscape? I can just tell from personal story. When I learned and I came back and I started doing, I worked in a government hospital. So when I would do a surgery, patients would agree because it was a free surgery, and I was telling them that this is as safe, and would show the pictures that I carried from Milan. So I could get patients, but the post-treatment kind of this thing was very variable. Breast would look good, they will go for radiation therapy, and people will question, "Arey, kya surgery hai? Where is your tumor and what has been done?" So for first 10 years, I struggled to use those techniques to patients who would be very good candidates. I sent, I think, 2 articles to Indian Journal of Surgery as a review or something. They rejected, saying that it is not being practiced in India, so what is the need to talk about it? So that was kind of I would say 2003-04 to 2010 when ABSI was formed, and in 2013 ABSICon in Chandigarh, I presented my 2 videos of superior inferior pedicle reduction myoplasty, and I heard somebody saying, "Ye to kahin se record karke laye hain." Who would have been doing that? At that time, even UK surgeons were not doing because they did not have the certification and all that, so they required training. And I remember Shankar telling me, "Arey, tum government hospital mein kya kaam kar rahi ho?" Anyhow, but my scope was limited. I worked in a medical college. I could only do that much. But there were many more who did so much better work. Dr. Kopikar, who started in 2008, came back. He started, he had his own hospital, lot of work. He trained many more. And in the, I think, 2010 to 2015, it was only few videos which I had recorded and I was showing, and Professor Kopikar would come and share a lot of work. And then I think 2015 onwards, a lot of young generation, I would say second generation of breast surgeons trained at better centers with all the newer techniques which were added later on. And then we have a movement. Since then, it has just picked up. So acceptance, awareness, skill learning has been tremendous post that. So in 2025-26, we are saying that we have, it has been accepted, is growing, but adoption is uneven. It is mostly in the urban centers and tertiary care centers, and in the periphery we are trying to increase the outreach. So these kind of workshops, I said yesterday also, are the ones which will take the techniques to tier 2, tier 3 cities, so that more and more patients can benefit. This was the paper published by Professor Kopikar in 2019 in Indian Journal of Surgery. So after my aborted attempt about 20 years back, this paper got accepted, and with a lot of solid work at that point of time. What are the challenges? We have resource constraints. There is training gap. Acceptance may not be as great. We have to create more and more awareness amongst the referring physicians, as well as take away the fear from the patient's mind. And also, factor in the cost and accessibility, because it does take a lot of intensive follow-ups, proper all kind of treatments. We can't have shortcuts for this kind of procedures. How people are learning a lot of in these workshops. So workshops titled "What You Can Do, Learn, See Today and Do Tomorrow" kind of a theme have been part of ABSI programs. We have fellowships mostly by the private institutions. We have MCH program by Dr. Kopikar. Then there are various courses which are being run by SGPGI, PGI Chandigarh, postdoctoral certificate courses. We have MCH at some centers in breast and endocrine. And then Professor Sanjay, Dr. Sanjay, Dr. Ashutosh have been I think the torchbearers of oncoplastic surgery, conducting workshops and training more and more surgeons. So that's my last slide. How do we go from there? I think yesterday, Rishi, you said we are over-regulated, and our problem is very little regulation. So what we have to now ensure, now that more and more people are trained, we also have safety checks in place so that the procedures are practiced with due safety and consideration, and patients do not end up with half-botched procedures, half treatments, and poor outcomes. So it has to go beyond urban centers to the periphery. We have to kind of develop, because breast as a subspecialty is important. Number of cases are enormous. The need is there, and so much of advancement is there. So I think it has to go beyond the general surgery department as independent units, and more developments are going to come with AI going to be an important partner in delivering this care. So with that, I would say we have to go forwards in many directions. Our role may be shrinking in some, our role may be expanding in some. And somebody very funnily told me, I had not talked about robotic. That is another area, a new tool when people are experimenting. And Professor Toyska, who's the father of robotic breast surgery, he said it's funny that we are offering prophylactic mastectomies to people who don't have cancers, and we are saying no surgery for patients who have cancers. So in which direction this thing moves, paradigm moves, only time will tell. Interesting times ahead, and I hope we all will continue to practice with due consideration to safety of the procedure and keeping the patient's best interest in mind. Thank you so much.
Thank you. Beautiful presentation, and then quite comprehensive as far as the constraints and the future plans you have. We are running behind the time. We'll take one question maximum.
And you laid the lay of the land in front of us. I just have one question for you. We are talking about de-escalating, and from mastectomy we are moving towards the breast conservation surgery because we are de-escalating. But by doing extreme oncoplasty, we are not really de-escalating, are we?
Right.
We are in fact escalating. What's your opinion about that?
I think first and foremost we have to be sure that it remains safe. Extent of surgery doesn't really matter. When we say of robotic surgery, it is minimal excess, but it is not minimally invasive. For a medial quadrant tumor, you will raise the whole skin envelope from axilla and go there. So invasion extent matters to the patient's overall homeostasis. And I remember just the comment. Professor Pitti was doing a study on inflammatory markers in oncoplastic breast surgeries at that time when I was training. And they found that patients really have a lot of systemic inflammation after these procedures, and they do matter in patients' overall recovery and so many other things. But we don't talk about that. So we don't talk about issues which are not comfortable to us. And somehow evidence gets generated, and as somebody again said, if you torture the data too much, it will confess to anything. So it's what we get what we want to see as guidelines and believe in, and hopefully we do the right thing.
Thank you. Thank you very much, Dr. Navneet. Thank you very much. Bye.
Thank you very much, Navneet ma'am, and a special thanks to our chairperson. It's time for photo session. Moving to the next session on the topic of redefining treatment outcomes with immunotherapy early triple negative breast cancer. I would like to invite our guest speaker, Dr. Avinash Pandey, SCMH Patna. It's my pleasure to invite to the dais our chairpersons, Dr. Prashant Kumar, AIIMS Patna, Dr. Amit Kumar, Dr. Anita Kumari. And I request Dr. Anita kindly introduce our next speaker.
At outset, I would like to express my gratitude to organizing team especially Dr. V.P. Singh sir for giving this opportunity to chair this session. And it's my pleasure to welcome you all for this session, redefining the treatment and outcome and role of immunotherapy in triple negative breast cancer. And for this we have our esteemed expert, Dr. Avinash Pandey, who did DM from the TMH Mumbai, and he was ex-assistant professor in IGIMS Patna and ex-associated professor in AIIMS Patna, and at present he is a senior consultant medical oncology at Savera Cancer Multiple Hospital. And now hand over mic to Dr. Avinash Pandey.
Thank you very much for the kind introduction. I'd like to thank Dr. V.P. Singh sir for giving me this opportunity. So in next 10-15 minutes, we are going to see how immunotherapy are now being integrated into the management of triple negative breast cancer. So in the next 10 minutes, we are going to see why triple negative breast cancer is so much important for developing countries such as India, how it is different than a conventional hormone positive breast cancer, and how immunotherapy can be combined to a normal chemotherapy to improve the outcome, which includes event-free survival and overall survival. So in India, about 1.5 to 2 lakh women are being diagnosed with breast cancer, of which 90,000 mortality is there every year. And 1/5 to 1/4 of all the breast cancers are triple negative breast cancer. And if you see in India, the percentage is about 10 to 15% higher compared to the Western population. So we have a higher volume of ladies coming with a breast cancer who happen to be a triple negative breast cancer. Not only that, we are seeing younger women, even girls at about 18 years of age, even women about 24, 27 years of age, presenting with a triple negative breast cancer. And breast cancer in triple negative, especially in Indian population, happens to be of a higher grade. They happen to have a greater nodal burden. They happen to have a higher size of the primary tumor compared to a hormone positive cohort of breast cancers. And hence they have higher chances of likelihood of the disease coming back. If you see this slide carefully, if the disease comes back in this patient as a recurrence, the red square, if there is any recurrence outside the breast, the 3-year survival rate is 20%, which is quite different than a hormone positive. Even in a hormone positive now, the 3-year survival rate is beyond 50%, but in triple negative, it's very dismal. If the disease comes back, the patient generally have a poorer survival. If you see, compared to a traditional breast cancer, the triple negative breast cancer, the disease comes back within 1.5 years to 2 years, compared to 3 to 4 years in a hormone positive breast cancer. Now, conventional chemotherapy regimes which we have been using, including anthracyclines, alkylating agents, as well as taxanes, gives a pathological complete response in about 30 to 40% of cases. But adding immunotherapy over it increases the pathological response rates by more than 15%. That is from 50 to 65. Now, as we have discussed in our previous panel discussion as well, in HER2 positive breast cancer as well as in triple negative breast cancer, the very important paradigm is to achieve a pathological CR. So whichever treatment modality, which includes either immunotherapy, chemotherapy, or a combination of targeted therapy, gives a higher percentage point of pathological CR, because these patients who achieve a pathological CR, they will have a much better outcome in terms of survival. And if the disease is allowed to undergo a relapse or a residual disease, then these patients will have a very shorter disease-free interval and hence a poor lifespan. So, so in triple negative breast cancer, how the immunotherapy can be combined with the chemotherapy. So generally in the trial which are going to discuss, a Keynote 522, they have compared taxanes and carboplatin and combined with pembrolizumab, which we also known as a Keytruda, followed by another cycles of cyclophosphamide and adriamycin plus Keytruda, then surgery, and then followed by adjuvant pembrolizumab for a period of 1 year. If there's a pathological CR, it's well and good. If there's a not pathological CR, then the patient undergoes capecitabine for additional adjuvant therapy. So the conclusion of this trial, which I like to begin with, is that if you see on the left side lower corner, the EFS, event-free survival, is about 0.63, which is about 37% improvement in event-free survival. the patients receiving Keytruda or pembrolizumab over and above chemotherapy in these particular patients. And if you see the data coming from the UK, there are a lot of women who would want to have a breast conservation surgery, but that they couldn't get the chance because neoadjuvant chemotherapy wasn't sufficient enough to downgrade an advanced tumor into a resectable breast cancer. So this opportunity is lost, and they undergo getting an MRM instead of a BCT done. So if we can increase the response rates, more number of women can be turned into breast conservation surgery. So benefit of neoadjuvant chemotherapy, most of us are aware of, is decreasing the size of the tumor, allowing more higher percentage of the patients to undergo a BCS. And we also undergo a response prediction. More than 80% of the patients do have a significant response after beginning of chemotherapy, which we need to monitor. Higher the pathological response, we know the patient will survive for a longer period of time. We can assess the role of chemo as well as targeted therapy or immunotherapy if we give it as a neoadjuvant setting. And we can reduce the axillary surgery burden, and hence subsequent incidences of lymphedema can be reduced by preventing a larger surgical axillary dissection. Now, compared to a hormone-positive breast cancer, triple-negative breast cancer is a highly immunogenic. If you see the data about PD-L1 expression in more than 1% of the patients, about 85% of the triple-negative breast cancer have a PD-L1 expression of more than 1%. And blockage of this PD-L1, PD-1 axis is known to improve the response rates in this cohort of patients. Hence, we are discussing this trial, which is a Keynote 522 trial. So this molecule Keytruda has been combined, as we have discussed with before, either 3-weekly carboplatin plus paclitaxel or weekly paclitaxel plus 3-weekly carboplatin for 4 cycles every 3 weekly, and then further 4 cycles of Keytruda plus doxorubicin and cyclophosphamide, which we generally used. So after completion of the entire duration of 4 plus 4 cycles of immunotherapy and chemotherapy, we subject the patients to surgery, and then we continued the Keytruda for a duration of 1 year. So this is the schema of the trial, which we have just seen before. Now it's important to note here is that, see the right hand side, the T2 happens to be 70% of the patients. So 70% of the patients, or about almost 80% of the patients, are T1 and T2, and about N0 and N1, which is about 50 plus 40. So 90% of the patients are N0, N1, and 80% of the patients are T1, T2. So they are early triple-negative breast cancer, and 75% of the patients are stage 2. So this truly denotes an early triple-negative breast cancer. We are now safely using immunotherapy and combination chemotherapy to begin with all 8 cycles. Now, this is very less often seen. If you see the lowest curve there, which is 0.02 forest plot hazard ratio, that means 80% reduction in mortality, in overall survival. If you see the hazard ratio is 0.22, which is 78 percentage point lesser or improvement in overall survival if the patient achieves a pathological complete response, which is seen in 65% of this cohort of patients. This is very less seen in modern day clinical trials, about 80% reduction in mortality. Now, the primary endpoint of this trial was event-free survival, and patients who had achieved a pathological complete response, which is a T0, N0, the curve started separating at the end of 1 year, and it kept on separating even at the follow-up of 5 years, 6 years, and 7 years down the line. So, and obviously it was remarkably different in terms of statistical significance. So both EFS and overall survival kept on dividing at the end of 1 year, and the curves kept on separating. So patients who achieve pathological CR not only have about 30 to 35% reduction in overall event-free survival, but about 70 to 80% reduction in overall survival as well. So pathological CRs, if you see the total group in C2 was 50 versus 65%, which is a 15% jump here. And if you see on the left-hand side bar diagram, if the patient has a node positive and you give immunotherapy plus chemotherapy, the conversion, or you say the delta, is 20.6. So in node positive patients, immunotherapy actually worked better with a 20% improvement in response rates, pathological response rates. Here also is the interim analysis of EFS, which shows a 7% improvement in EFS. And this is the entire population, not the pathological CR. So the entire population, the hazard ratio in EFS is 0.63, which is a 37% improvement by adding a immunotherapy drug over chemotherapy backbone in neoadjuvant setting. And the difference here is 95 versus 56% if there's a pathological complete response by EFS. So if the patient achieves pathological CR, he's having a delta of about 30% higher event-free survival. So in short, always try to get a pathological CR, use immunotherapy to boost the effect of chemotherapy in this. Safety data is very well matched between placebo and the experimental arm. Only the diarrheas are slightly bit higher on the immunotherapy compared to a chemotherapy arm. And overall, the event-free survival, if you see exactly on the left, confidence interval is also on the totally left side of the forest plot, which is about 0.63. So in short, I would like to say the event-free survival is much longer in Keytruda, and Keytruda was associated with a overall survival benefit if the patient has achieved a pathological complete response after immunotherapy and chemotherapy exposure by a significant margin. So I'd like to conclude this entire summary into few short lines. Previously, a decade back, dose-dense chemotherapy, which includes AC and taxane with or without platinum, had been the backbone of chemotherapy. Now, combining Keytruda or pembrolizumab over this chemotherapy background increases the response rates, increases the breast conservation surgery, and increases the pathological CR rate. Higher the pathological CR rate, which is about 15% higher, leads to a better and longer event-free survival and overall survival. And this conventional dose dense provides only about 30 to 40% PCR rates, but Keytruda addition to a chemotherapy improves the pathological CR by 60 to 65%. So it's about 15 to 17% improvement in pathological CR. So that was my last slide. Thank you very much. So in short, addition of immunotherapy over dose dense or normal chemotherapy in triple negative breast cancer makes the patient having a longer event-free survival and making the patient live longer with a longer overall survival. So thank you very much. That was my last slide. Thank you for the opportunity.
Thank you so much, boss. It was very nice, very elaborative TNBC treatment with adding pembrolizumab. So any question from the audience, since we have adequate time? No. Sir, I have one question. Patient of TNBC comes to you, so do you routinely start pembrolizumab along with conventional chemotherapy?
Yeah, so we have
or you starts with conventional chemotherapy, then see the response and then add pembrolizumab.
So we have 3 patients who are on neoadjuvant pembrolizumab. Affordability comes with the picture. I do PDL1 for all my patients. Though in trial, anyone having a PDL1 more than 1% had a benefit, whether it is less than 10% or more than 10%, both cohort had a similar benefit. So if I would not give immunotherapy, even if the patient is affording, if the PDL1 is less than 1%, the reason being in that trial only 11% patients had a PDL1 less than 1%, and the data for that is not released yet, that what was the outcome. So in short, if the patient is affording, I will combine immunotherapy and over chemotherapy in all my patients, even in early triple negative breast cancer, if cost is not a concern. And if they have PD-L1 positivity, more than 1% at least.
One question, as a nice presentation, as is early stage with triple negative, would you like to go with BCS or MRM in your patients?
Yeah,
what's your choice?
So
or you go with complete response accordingly?
So we'll
That's
be
our
placing,
job,
we'll be
That's
placing
our job.
We'll be placing a marker to begin with before neoadjuvant chemotherapy. We'll complete the entire 8 cycles with immunotherapy, and then we'll consider for a BCS. That was the entire objective of making the patient undergo a BCS from a MRM. That was the intention to begin with. Yes, sir, you were asking something?
Sir, isn't it logical you start with conventional chemotherapy, see the response, and if response is not satisfactory, then add pembrolizumab?
See, in the real world scenario, you can trained to do that. There is no as such data or a clinical trial addressing that you give 4 cycles of chemotherapy and then you think the response is not adequate, you add immunotherapy. You see, the entire objective is to achieve a pathological CR. For that, you need to do a BCS. So there is one trial which is showing that if you complete the entire 8 cycles of chemotherapy and there is a residual disease at the end of BCS, then you can add immunotherapy later. That makes some sense. That has improvement in event-free survival. But checking clinical response, not having good quality clinical response, and then adding immunotherapy over the next 4 cycles, we don't have data for that to begin with. So I'll advise, if the patient is affording, if PD-L1 is more than 1%, you can go ahead with the immuno and chemotherapy to begin with.
I think that the data is in a reverse direction. So you give chemotherapy and immunotherapy both, assess the response after 2 or 3 cycles, and then try to de-escalate as per the train and the both in the HER2 positive and TNBC. So data is in the reverse direction.
Yeah, in
so
immunotherapy, we don't down escalate. In immunotherapy, most of the trials we have given to 1 year, even in adjuvant setting.
And we have the trial from the AIIMS itself, so the low dose pembro, and probably it will be helpful in our setting once we'll see the full publication.
Yeah, so
I think it was published already in the Annals of Oncology.
So we have a low dose nivolumab generic which has come, which has reduced the cost of immunotherapy to about 50,000 only. So that makes sense. So now immunotherapy being more affordable, we can expand the use of immunotherapy across the board if the patient is eligible. Yes. Yes, you can go ahead.
Okay, I just wanted to ask, did you say that you do PDL for early breast cancer in neoadjuvant setting? That's interesting because I always you wonder, despite the fact that Keynote 522 didn't have that.
No, it had it.
But that didn't mandate
that
use
didn't
of
mandate.
PD.
That was a subset analysis because 85% of the patients had PD-L1 more than 1%.
Okay.
So it's almost 1 out of 20 will have less than 1% PD-L1 in triple negative breast cancer. So in blanket, almost everyone gets immunotherapy because PD-L1 expression is more than 85% anyway. And patients who had more than 10% versus less than 10%, there was no difference in terms of pathological CR rates. So in short, even if it is 9 versus 19 versus 2, the outcome is more or less the same across the board.
Yeah, well, I am with you on that because why do we not do it? If we do it in metastatic setting, then why do we not do it earlier?
Yeah, so I'm not trying to push the surgeons away from surgery in case you're answering that. But yeah, most of the drugs are jumping into the neoadjuvant phase. So we are going to see entire intention is to bring the pathological CR as high as possible. So we went from 20-30% to 40% to 50%, now 65%. Maybe down the line it might go exceed 70%. The whole idea is to get the pathological CR so the patient lives longer and a better life. So thank you very much. Okay, thank you. Thank you so much.
It's time for the photo session. Kindly come forward. Our chairperson and speaker. It was a wonderful session. Please put your hands together. Ladies and gentlemen, it's time for some sparks. It's time for debate session. And the motion for the debate is sentinel lymph node biopsy post NACT. I may invite as a moderator on the stage Dr. Ashutosh Mishra, Dr. VP Singh, Dr. Roshan BA. And let's welcome our speaker for debate, Dr. Paulami Mukherjee speaking for the motion and Dr. Manjula Rao speaking against it.
Thank you so much. So first of all, I would like to invite Dr. Paulami Mukherjee. She is surgical oncologist and Cancer Hospital and Research Center in Assam, and she is speaking for yeah.
These are the current body of evidences for my various points that I put forth. Right, so sentinel lymph node biopsy should be considered after NACT. Sentinel lymph node biopsy as a concept, it's pretty much established in the early breast cancer. Plenty of evidence supporting it, and this is the standard of care. This entire concept is just an extension from the early breast cancer to the NACT setting. So here we are, the first very important point. It forms a part of de-escalation of the surgery, avoids axillary dissection in a huge group of patients, and hence significantly reduces the lymphedema, shoulder dysfunction, neuropathy. So this entire concept actually aligns very seamlessly with the modern minimally invasive oncology that we are practicing today. Again, it is a very important minimally invasive method for accurate post-NACT staging in a way that it reflects the tumor biology and response to therapy, though not the initial burden, and it very efficiently identifies the nodal pathological complete response rates. When we look at the PCR rates in the axilla, the modern molecules have pushed it to almost 80%. See, initially, a decade ago, we were looking at PCR rates of about 30 to 40% in the axilla with the molecules that were available that time. But currently, we have the dual HER2 inhibitors, and that pushes it to almost 80%. So we have this huge percentage of patients who would actually unnecessarily go through the toxicities of an axillary dissection when we actually have an alternate minimally invasive and a much less complicated staging procedure to offer. Again, we do have acceptable accuracy with modern technique. So we are looking at two main benchmarks here, the identification rate and the false negative rate, which we have chosen as accuracy methods to ascertain the accuracy for this sentinel lymph node. So what you have here is that when we use the dual tracer technique, when we retrieve nodes that's about 2 to 3 nodes in number, and when we use a targeted axillary dissection, we can actually reduce the false negative rates to less than 10%, which is a benchmark from the early breast cancer. So we have a meta-analysis to support. We have 21 meta-analysis from China, which looks at 21 studies and 1,700 patients. And here the identification rate is well above 90%. The false negative rates were about 8%. So there's obviously no debate here. The patients who had an initially N0, clinically N0 axilla, you give them NACT, they are still N0. Sentinel lymph node biopsy in this scenario is pretty much accepted. Now, where does it get a little more complicated is when a patient with an initially node positive axilla converts to a clinically node negative setting after you give them NACT. So this is a current meta-analysis, the largest pool data, where the identification rate is about 88%, slightly missing the benchmark. The false negative rates here was between 13 to 14%, and what this meta-analysis actually said is, it is feasible with borderline accuracy, may not be reliable unless it is optimized. Now let's read these words very carefully. We need to optimize this procedure instead of totally dissing it. So this key finding across all meta-analysis had this consistent pattern where we do have a very reliable identification rate, slightly lower than upfront surgery, but acceptable. Now, when we are looking at reduction in FNR rates, we have very reliable methods, again proven by meta-analysis. Retrieval of more than 3 sentinel lymph nodes would bring down the FNR to less than 10%. Some trials it has shown to be 8%. The dual tracer technique again improves the identification and reduces the FNR. The targeted axillary dissection technique coming up in a very big way. When you clip the the removal of the clip nodes and then do the along with the sentinel lymph node, the FNRs are reduced to 5%. And of course, it cannot be understated, a careful patient selection where the patients have actually converted to an N0 axilla after the NACT. So the evidence from the landmark trials, including ACOZOG Z1071, actually support this. So their FNR rates had reduced to 10% when they harvested more than 2 nodes with a dual tracer technique. Now, more importantly, even if your FNR rates slightly higher than the benchmark, it does not actually translate to a reduced survival, which is very important. The lower axillary recurrence rates were just about 1 to 3% in most of the studies, and there was no significant differences in the DFS and the overall survival. So of course, we have the support from radiotherapy and the correct systemic therapy to compensate for this, but then again, there is no strong evidence for a worse survival. So why are we looking at a procedure which will give you more toxicity than this particular sentinel lymph node that could actually afford you a good oncological outcome with very less toxicities? Here I've just put up certain retrospective studies that have actually used sentinel lymph node alone without the targeted axillary dissection. And we can well see that the recurrence rates were pretty negligible. The highest recurrence rates was 1.6% with no difference in the overall survival or the disease-free survival. So here we are good to go. Sentinel lymph node biopsy should be done in an NACT setting. Again, it's a part of personalized treatment. Our entire, the core essence of this conference today, personalizing treatment, and that is one of the important pillars where you can actually look at whether the patient needs an ALND. We can make certain important radiation decisions and also decisions regarding the adjuvant systemic therapy. Again, last but not the least, improvement in the quality of life. It's a less morbid procedure, less long-term toxicity, and converting to better survivorship outcome. So with this, I come to the conclusion that though we have the false negative rates may be slightly higher in the older studies, but the current body of evidence do suggest SLNB as a very acceptable alternative to an ALND in patients who converts to an N0 axilla after the NACT, and hence reduction in morbidity without compromising surgical staging. So I would definitely support SLNB in the setting of NACT with certain optimizations to my technique. Thank you very much.
Thank you. Now I request Dr. Manjula Rao to fight against the motion that post-NACT sentinel lymph node biopsy is bringing more trouble.
Dr. Manjula is oncoplastic breast surgeon at Proton Center, Chennai. A very renowned surgeon, I suppose. Thank you.
Thank you very much for the introduction. Very good afternoon, everyone. I will be speaking against the motion that sentinel lymph node biopsy after neoadjuvant chemotherapy can safely replace axillary dissection. Now let me emphasize, I am not debating SLNB as a proven technique in order to de-escalate axillary staging, or the reduced morbidity that it offers, or the increasing rates of PCR that we achieve today with modern therapy. This is not about resisting, okay, that's fine. So this is not about resisting innovation, but it's about asking, are we ready to trust it in the real world? So let's start why this matters. Axillary staging is not just academic. It directly drives radiation decisions, systemic therapy, and most importantly, prognosis. Now, missing residual nodal disease is not trivial. It has direct survival implications, and if we understage, we undertreat. So the real question is simple. Can we safely rely on sentinel lymph node biopsy after NACT? And for that to be true, 3 things must hold. 1, a low false negative rate, oncological safety, and reproducibility in real world settings, because our goal is accurate axillary staging. Now let's talk about biology, because this is where the problem begins. Neoadjuvant chemotherapy alters lymphatic drainage. Fibrosis develops, and this leads to altered tracer uptake, and tumor response is also uneven. So the node that we identify by SLNB may not actually represent the true residual disease burden, and also microscopic disease can get missed. So that brings us to the crux. False negative rates. An acceptable benchmark is less than 10%. But studies like the ACASOG Z107 and Sentina, etc., have consistently shown an FNR of more than 10%. There is only one study, the SN-FNAC trial, which has reported a very favorable low FNR of 8.4%. But that has been derived under very strict conditions. So acceptable accuracy has been attained only under very ideal, controlled environments, not in routine practice. So to reduce false negative rates, we need a perfect setup. We need dual tracers, methylene blue, radioactive colloid, ICG. At least 3 or more sentinel lymph nodes have to be retrieved, and targeted axillary dissection, which, mind you, requires additional resources and skills like placement of clips prior to NACT, wire insertions, etc. So, I ask you, are these conditions consistently achievable in our scenario? Let's look at the real world scenario. Let's look at the Indian scenario. So here's a very nice publication by from my colleague, Dr. Sanjay Yadav from Jabalpur, where they've looked at the sentinel lymph node biopsy post NACT using low-cost dual dye. And low-cost, so they have looked at methylene blue and an alternate dye called the fluorescein dye, because it's a low-cost setting, right? And if you can see, the identification rates are consistently low, less than 90%. And moreover, the FNR is also quite high, in some cases as high as 25%. He was only able to bring it down when a more number of lymph nodes were excised. So, in the real world, applicability varies because systems vary. In terms of surgical expertise, the nuclear medicine support, ICG infrastructure, clip and wire placement practices, expertise, costs, patient affordability. So this leads to one thing, inconsistent implementation, which leads to inconsistent outcomes. So yes, while the scientific data looks appealing and supports de-escalating axillary staging post-NACT, can this be adopted routinely in our setting, in the real-world scenario? So let's be honest. If a technique works only in the perfect hands, perfect infrastructure, perfectly curated conditions, can it truly be standard of care? Guidelines assume ideal systems, but we do not always practice in ideal systems. And what about long-term outcomes? We still lack robust survival data. Most studies focus on accuracy. They looked at more number of patients who were clinically node negative and low axillary nodal burden positivity. And let's face it, in our scenario, that's not what we see routinely. We see high nodal burden positivities. We see N2 disease consistently. So most studies here that we see are focusing on the accuracy, and we are extrapolating safety. We are not proving it. So let's break it down clinically. Yes, clinically node negative axilla post NACT, you can
attempt an SLNB. When N1 turns to N0, again there is scientific evidence, but definitely not when in N2 disease, right? But in the real world scenario, all of this can be achieved only when we have the ideal conditions. So to conclude, SLNB post NACT is technically promising and it's a fantastic technique, but it is not universally reliable. Until it is consistently accurate, reproducible, and oncologically proven. So slow down. It should not replace axillary dissection. De-escalation is appealing and it is ideal, but not at the cost of leaving disease behind or treating inadequately. Thank you.
Thank you, Dr. Manjula. Now I request Dr. Palmi for the rebuttal. 1-2 minutes.
Thank you, Dr. Manjula. First and the foremost, we are looking at missing microscopic disease. And if I had the support of my medical oncology and radiation oncology colleagues, this can be very well taken care of by the adjuvant therapies. And it is happening because just leaving microscopic disease is not exactly translating to less of survival, less oncological or inferior oncological outcomes. Number two, when we are looking at a process, when we look at a surgical procedure, it always comes through phases. This is called the learning curve. And as surgeons, we will never become obsolete because we have that inherent capability to evolve. So today, when a procedure looks not very practical, complicated, in a couple of years, this will be the standard that we do without second thoughts. So let us give ourselves that break, that as surgeons, that confidence that as surgeons, we will perfect this technique. And resources in our country, if I can speak for India, are becoming more and more, we are looking at less resources right now, but that may not be the scenario a couple of years down the line. So just not doing this procedure because the conditions are not perfect, I don't think is really why we should not do at all. We have to perfect ourselves, we have to bring in resources, and then only we can actually have this as the standard of care. And number three, the trials, the landmark trials were actually a little dated. They were all done in 2015 and 2014. So we have this 15 years, we are standing here, and we are looking at evidences that was a decade ago. It does not, the modern times, the modern techniques, and with the modern facilities that we have much better outcome when we bring in sentinel lymph node biopsy in the setting of NACT. So yes, we are putting our boundaries, we are improving standards, we are pushing our boundaries, but then that's the core of what we do. We do not feel scared because the procedure is not perfect. We are the ones who need to perfect it. So I think we have to look at it under this light. We have to bring and do this in the regular practice. And definitely, as in India, we should have our own data. And therefore, I'm very confident in the next couple of years, this will be the standard of care. And we are going to do this procedure for a higher disease burden, even in the axilla. Thank you so much.
Dr. Manjula.
Fantastic. Thank you, Dr. Palmi. Actually, she's spoken in support of me. And why I say that is because I do not disagree with you on various fronts. It's a fantastic technique, and I think it is a technique of the future in our setting. But what are we debating here today? We're talking about widespread applicability, the safety of the technique. So while we have scientific evidence allowing it, to be introduced and incorporated in guidelines, can it be practiced in our scenario routinely, currently? Maybe a few lucky centers, like for example where I am at Apollo Proton Cancer Center, yes. But maybe in a Jabalpur, because we have the data, maybe even in centers in Patna, can this be done accurately, achieve consistently, not unless we have all the resources available to us. So while we are having this debate with an audience of trained professionals and those in training, I think it's very important to emphasize here that guidelines are there to guide us, but we can apply it only when we do achieve the ideal conditions under which those guidelines have been crafted. Thank you.
Thank you so much. So just to summarize the session, for all the sake of residents, post-anesthetic axilla, if there is N2, N3 disease in the axilla before chemotherapy, and even if it turned out to be N0 after chemotherapy, standard is ALND. I think houses agree. Okay. If N0 before chemotherapy, then again N0, so sentinel lymph node biopsy is the standard procedure. Houses agree for that. Now the question is N1 or N plus that turned out to be N0. So there is a debate. For that debate, we need to consider dual dye technique, 3 lymph nodes, and your false negative rate should be less than 10%. So that's the idea behind all the trial, Sentinel, SNFNAC, and 1071. So these are the trial. So there is a limited circumstances where we are going for sentinel lymph node biopsy. So the question was about the feasibility of the sentinel lymph node biopsy. Yes, it's doable. And after doing in those circumstances, recurrence rate is 1 to 2%. Or when you are doing TED, you are targeting the lymph nodes. So you are removing that targeted lymph nodes and also doing the sentinel lymph node biopsy, removing sentinel lymph nodes. So your false negative rates are still decreasing. So yes, de-escalation is the way, but there is a subset where we can apply the de-escalation. So I think from my sides, both are winner. You need to understand the situations where to de-escalate the disease and where you have to go. Thank you, everyone.
I would like to add upon, definitely the situation, if it is ideal and in the expert hand, definitely you can go ahead. But every day, every time, and the situation may not be the same, so you may differ. So here I agree with Dr. Sutosh that both are winner, because ideal situation and actual situation differs totally. So your point?
So we're being diplomats today.
Wonderful debate session. It's time for photo session. Kindly come forward. बहुत खूबसूरत तरीके से पेश किया गया था. मैं चाहती हूँ एक बार हमारी मैम्स के लिए जोरदार तालियां होनी चाहिए. Thank you ladies and thank you gentlemen. We now transition to our panel discussion. Moving to the next session, another panel discussion. And the theme of our panel is triple negative breast cancer. To lead this session, I may invite as a moderator. Ladies and gentlemen, जोरदार तालियों से स्वागत कीजिए Dr. Sanjeet Agarwal, TMC Kolkata. I may invite our chairpersons, Dr. P.K. Jha, Dr. Pradeep Jaiswal, Dr. Jarang Rajesh Kumar to the dais. जोरदार तालियों से स्वागत कीजिए. And I also invite our eminent panelist, Dr. Rishikesh Parmeshwar, Dr. Amit Kumar, Dr. Abhishek Anand, Dr. Arvind Kumar, Dr. Ranjan Kumar, Dr. Shambhavi Sharma, Dr. Amrita Rakesh. Kindly join to the dais. And I request Dr. Sanjit Agarwal take this stage. Over to you, sir.
So thank you very much again. And what we are trying to focus now is the triple negative breast cancer. Almost all of the thing you have seen bits and pieces from the morning itself about immunotherapy presentation in TNBC and how we de-escalate surgery as per the response. So we have eminent panelists across the board of the tumor board. So that's the importance of the tumor board itself. If you see the panelists here, so we have medical oncologist, surgical oncologist, radiotherapist, and all the supporting radiologist and pathologist. I will not say it's a supportive, it's a prime department now for us to give the idea of how we treat the patient of any breast cancer, leave triple negative, HER2 positive, or PR positive and HER2 negative breast cancer. So coming to the triple negative breast cancer, Dr. Amit, so how you see the triple negative breast cancer in India? So we see a lot of the Western data of TNBC, and we see that the percentage of the patient what we see in TNBC is around 10 to 20%. So do you feel that same data holds true for the India also regarding TNBC percentage?
No, I don't think so. In my personal practice, and if the data says, you see the data of India, if you see the data of Bihar, so proportion of TNBC in this part, I mean even in Bihar, is very high, around 30 to 35%. Indian data also says the incidence is around 30 to 35%. So it's much higher than Western data.
Why it's so? So any specific reason why we are seeing more triple negative breast cancer? Any explanation? Because we say that we see a lot of triple negative breast cancer, but is there any region of seeing more triple negative breast cancer in India?
Reason I cannot say.
So one is younger, so we have younger population, we may say that we have younger population, so we
what
say...
we are seeing in India is more of triple negative breast cancer as compared to the Western countries, and the range is between like 20 to 30%, and there are many data from TMH, Kidwai and AIIMS also, I think that suggests it is between 20 to 25%. Reason, the most important is the disease biology, and the second thing is the how we are testing the ER/PR and HER2 status. Many of the ER/PR HER2 IHC tests are being done in the periphery. That is not standardized, and because of that we are lacking the positivity among these receptors, and when we are repeating these tests in the standardized labs, and we are getting the positivity.
So
that
completely agree with him.
Also.
So if you see the data of triple negative breast cancer in 2010, which was published by ICMR from multiple institutes, it was around 30 to 50%. But now when we are seeing the data of recent data from multiple institutions, it's almost cornering around 15 to 20%. So reason was probably two. One is more young breast cancer where triple negative is more, and probably quality of the IHC also, because probably we have labeled many ER positive patients as a ER negative and treated them as a TNBC. So same question to Dr. Arvind. Do you feel that triple negative breast cancer should be treated differently and it has worse survival compared to other type of the breast cancer? Why we talk so much about triple negative breast cancer? And any survival pattern you see in the follow-up, that which year we should be more careful?
It has a worse survival. I don't think so. If you treat it aggressively, and whatever it had to do, it will do within 2 to 3 years. If you lapse 3 years passage on with a good intent, the patient is more or less cured.
So what he is saying that the chances of recurrence are generally higher in the early treatment, initial treatment, first 3 to 4 years, and then if the patient is surviving till 4 years, chances of survival, the recurrence is much less. So we see the different pattern of recurrence in ER positive, HER2 negative compared to the TNBC. And when you are thinking for a follow-up program in the TNBC, it should be different than ER positive and HER2 negative breast cancer patient. So coming to the Dr. Samvi here, sorry if it's a tongue twister name. So Can you explain about how you define ER/PR HER2 receptor in routine pathological examination and label this as a triple negative? We talk about lot of quality maintenance for the ER/PR. If you can give us the idea of little bit about how you maintain the quality of ER/PR and HER2 reporting.
Sir, for good ER/PR HER2 new reporting, the most important factor to be taken into consideration is the tissue fixation. The tissue should be, the cold fixation time should be taken into consideration, and the tissue should be fixed. The fixation time should not exceed beyond 72 hours. If the fixation time is less than 6 hours or beyond 72 hours, it affects the immunohistochemical response. And because of that, a lot of tumor has been erroneously reported as negative, because they tend to lose their receptivity if the fixation has been delayed and the grossing has been delayed. So, so that is why in today's practice it is preferred that the tissue, that the core biopsies should be processed along with the immunohistochemical response. And it is always preferred to be tested on the small biopsies than on the resection specimens. We only go for the resection specimen tissues if the biopsy tissues are very small or the tissue has been completely burned out due to repeated deep cuts and all, then only we go for a resection tissue. Otherwise, we always prefer to do a ER/PR on a core biopsy tissue, because that takes a lesser time for fixation and gives a better response.
So that's the point I want to give you to the, that immediate fixation and the core biopsy specimen is preferable for doing ER/PR and HER2 in any receptor status, because it will give you erroneous result if you delay the fixation. So when you are doing biopsy in the OPD clinic, try to fix it immediately and try to fix it with a proper solution. Don't make the solution as per you want. See the guideline and make a proper formalin solution, because that will affect your ER/PR and HER2 status and overall pace. It's a very simple thing, doable, but try to include in your practice if you have not done till now. So Dr. Rishi, please. So any difference in the triple negative over genomic or BRCA or tumor heterogeneity? So do you feel that these are different tumor compared to other subtype of the breast cancer?
Well, molecular profiling will tell that triple negative breast cancer are different from other subtypes. And the reason for that is how they respond to different treatment, and also how they behave, particularly being a heterogeneous group itself. We need to understand that their behavior is different from other subtypes.
Yeah, so let's go to the case example itself. So this was a 42-year female, pre-menopausal, completed family. So left breast cancer, 36 size, C-cup grade 3 ptosis. So left breast was 4 into 3 centimeter lump at 3 o'clock, 3 centimeter from NAC. Axilla has single mobile node, otherwise clinically normal examination. So this was the overall picture, and that's the tumor area we have marked on the left side of the breast. So coming to Dr. Amit again, so after this, how you will proceed in this patient? So clinical breast examination has been done. It looks like T2N1 disease clinically.
So first we will go for radiology, we will go for mammosonography, and after that we will proceed for the true cut biopsy.
Okay, so this is the mammography picture. So Dr. Ranjan, if you can explain the mammography picture of this patient, what you are seeing in this overall on the left side of the breast.
Yes, there is a round to oval solid appearing mass lesion in left breast with indistinct margin. So we should look this lesion on ultrasound also to further characterize the margin and the echogenicity, and then go for biopsy.
So probably you have not seen there is satellite lesion. It's not clear in this picture. So we had 2 lesions in this. Both were Barrett's 5 at 3 to 4 o'clock. You said that you will add ultrasonography in this. So any specific region you want to add ultrasound? What's the value we are adding with the ultrasonography here?
Because yes, on ultrasound we will see the echogenicity, then the orientation, whether it's a parallel oriented or it's a vertical oriented, and then posterior acoustic enhancement, then posterior caustic shadowing. So multiple features are there to label it as a malignant lesion. However, it is more obvious on mammography itself that it's a malignant lesion. But ultrasound also gives that it's a solid or cystic lesion or any necrotic component is there or not.
So any help in the axilla you feel that where ultrasound is better than mammography?
Definitely for axilla ultrasound I think is more better than mammography, because with ultrasound you can see the thickness of the cortex, then loss of fatty hilum, then size, then echogenicity, then what is the relationship with the vessels, whether it's encasing or not. So these are the added features we can see on ultrasound.
Dr. Amit, you want to say something?
No, the same thing I was.
So, Dr. Rishi, again, do you feel that we should add more investigation here, radiological?
Well, it is a dense breast. I don't think I'll add any imaging at this stage. I think I will wait for the histology confirmation, and we'll keep in mind that it is a complex density, and maybe I'll have in mind that MRI scan might help. If you have two distinct M5, U5 lesions and they're confirmed to be malignant, then take into account that I can't see very clearly from here, but it is fairly dense breast. So I'll bear that in mind.
So MRI is an option here. Probably you want to see the biopsy report and then decide upon the usability of the MRI.
Yes.
So this is the biopsy report. We have done the core biopsy from both the lesion. So both were triple negative. One was with little bit high Ki 67 and almost grade 3 and grade 2. So we have done FNSC of the axillary lymph node also. It was metastatic. So again to Dr. Ranjan, do you feel any additional radiological investigation is required before proceeding to the treatment?
We can go for MRI because MRI is more sensitive or most sensitive for detecting lesion or any other satellite lesion, and for lymph nodes also, and whether it's infiltrating to the underlying muscles. So these all we can accurately depict on MRI.
So this is T2N1 disease, and probably we'll go with the chemotherapy first because it's a triple negative. So do you think that we should do metastatic workup? It's a stage 2 breast cancer still. So by the guideline we should not do, but it's not required by the guidelines. So do you feel that we should do metastatic workup here? So all the panelists can answer their opinion. So you feel that metastatic workup should be done in stage 2 breast cancer here?
Multicentric disease, young patients, so definitely a CCT chest abdomen should be done.
CCT chest abdomen and bone scan, or only CCT chest and abdomen?
A good CCT scan can also comment on the bone. Alkaline phosphatase we can correlate, else we can go for a bone scan, but I think a good CCT chest abdomen should be done.
Dr. Rishi, you will do metastatic workup here?
As far as our guidelines say, it has to be N2 disease or a T3 disease. In a T2N1, normally we wouldn't do a staging, but I don't think it is unreasonable. There are evidences that it does help, but if you ask about our guideline, probably wouldn't be doing.
Even if you are sending for NSCT, you will not do PET-CT scan.
So,
unfortunately, no. That's
most of the guidelines do suggest that for stage T2 and 1, we should not be doing the routine metastatic workup unless there is a symptom. Like if there is a symptom of lung metastasis, you should go for the CCT chest. If there is a bony symptom, so you can go for the bone scan. But nowadays, what most clinicians are practicing, and there are few early evidence of few guidelines as well, that has incorporated metastatic workup in all the stage 2 disease, and specifically with the PET-CT scan whole body or CCT thorax, chest, abdomen, pelvis, along with the bone scan, because bony metastasis is also there in around 2 to 5% of the patient in clinically T2 and 1 disease. So ideally it should be done, considering it's a triple negative breast cancer, multifocal disease, And Ki67 is in one of the lump is more than 50%. So it should be done.
So if you see the guideline itself, it's different. So ISMO guidelines suggest to do metastatic workup, but NCCN and probably NHS is not very pro for doing metastatic workup. But in the NACT setting, if you are sending, you don't know it's a real N1 or N2 disease. You may say that it's an N1 disease. When we do surgery, we exactly know the nodal status, but in the NACT probably I will be also more towards doing metastatic workup. But if it is an adjuvant setting, probably I will not do metastatic workup in this setting. So the final is CT2N1 multifocal disease, and it's a triple negative breast cancer. We haven't done MRI in this patient, probably due to some reason, but ideally I agree with Dr. Rishi that MRI should have been done if we are planning the breast conservation surgery after this.
MRI must be done in this case because the disease you are supposing multifocal might be turned into multicentric, might be turned into bilateral. So MRI is the ideal choice.
So what we have done the mammography and we have done ultrasonography, and we have correlated it, and it was almost correlating. So ideal, yes, but sometime MRI, if you see in our center, MRI date is 25 days. So the waiting time of MRI breast is around 25 days, and then additional biopsy and everything, and that delays the treatment. Yeah. So that's the message we have already given, that MRI should be done in a selective patient. So this patient, again I am coming to the Dr. Samvi. So TNBC itself is not same. So TNBC is of different type. Yes, so is it possible for pathologists to characterize this in a different type and guide us? And do you feel that it's important at this stage to see the different TNBC and try to report in a that is a basal type or non-basal type of TNBC?
So for those, it is important because as per if we are able to categorize it on a basal type or a luminal type, luminal AR type, or a mesenchymal type, then we can know there are certain markers available, there are certain chemotherapies available which can be targeted, and a proper treatment can be achieved. And also in patients with triple negative breast cancer, if we are able to report the tumor infiltrating lymphocyte, that also helps, because if the tumor infiltrating lymphocytes are more, then it goes to a good prognosis type. So it is always good to mention it in the report, what is the state of the tumor infiltrating lymphocyte. Also, PD-L1 has a good role in triple negative breast cancers. If it comes positive, then it can be treated with the help of pembrolizumab. And basal type 1 and basal type 2 can also help in the treatment, because it has been, some case report has shown that basal type 1 has shown a good prognosis if they have been properly treated as compared to basal type 2. Also the mesenchymal type, if it is diagnosed on with a proper IHC, they tend to show a poor prognosis. So it is always helpful if we can lead the clinician with a proper marker, that they should go ahead with these markers. And also the histology type, because the triple negative breast cancers, along with the IDCs, there are metaplastic cancers, there are apocrine cancers, there are medullary type cancers, along with adenoid cystic cancers. These cancers also fall into triple negative breast cancers. So we can tell the clinician that histologically this is looking like this, so you should go ahead and get these markers tested, and on the basis of that, the treatment can be planned.
Dr. Rishi, you want to say something?
No, I agree with but you know, in real life, all we get, at least in NHS, that, you know, yes, it's a basal type or it's a metaplastic. They do all the clever markers, but we don't get PDL reporting for early breast cancer. It's only done when we have metastatic disease. So in this setting, all we will get that it is a triple negative breast cancer, or whether it is metaplastic or not, because that has significance as to how they might respond to neoadjuvant chemotherapy. But knowing that it is basal type is all we get. So yeah. I think you might be ahead here doing, and I'm quite impressed that you're doing PD-L1 here for early breast cancer as well. So and that makes sense. it will improve the PAT CR rate for your patients. But no, that's what we get.
We require gene expression profiling to characterize the triple negative breast cancer and to divide into the molecular subtypes. And the maximum utility of this characterization is in the advanced stage, where we can target those specific subtype with the targeted agents. Like AR receptors, we can target with the androgen receptor blockers. And for the mesenchymal and for the immunomodulated type, we can target with the immunotherapy. In the early setting, still the role is evolving for the molecular subtype based treatment strategies.
Yeah, I think there's some data suggesting TIL, what she has impressed upon, but I agree upon that is a more towards metastatic setting. But I think we should see the data of early breast cancer patient also. Coming to this patient, final diagnosis is T2N1 multifocal and triple negative breast cancer. So again, coming to the MDT itself. So for the surgical treatment, Dr. Amit, again, what you feel that upfront surgery or neoadjuvant? One line answer.
Neoadjuvant.
Why you are thinking for neoadjuvant? Any specific thing?
TNBC itself, is a candidate for NSCT.
What expected outcome you were thinking for surgical de-escalation here in this patient? So multifocal disease, but limited to one quadrant with lot of microcalcification there, and having a positive node in the axilla.
So ultimate outcome is obviously, ultimate expectation is obviously PCR, pathological complete response.
Any surgical advantage we get as a surgeon from giving chemotherapy?
Yeah, you can downstage, you can do the breast conservation surgery, you can avoid axillary dissection.
We have all discussed that we can de-escalate the mastectomy to breast conservation surgery, even breast conservation surgery, a level 2 oncoplasty to a simple surgery, and in the axilla we can de-escalate from ALND to sentinel in selected group of the patient. Coming to our medical oncologist colleague, what type of systemic therapy you are thinking for here? It's a CT2N1 disease in a triple negative breast cancer.
So now the standard is to add an immune checkpoint inhibitor, that is pembrolizumab, along with the chemotherapy backbone of paclitaxel and carboplatin. Once the 8 cycle, once the intended course of a neoadjuvant has been done, then we re-evaluate and then go for the surgery. So pembro along with paclitaxel and carboplatin. The paclitaxel is given weekly, carboplatin 3 weekly, and pembro again 3 weekly dose.
So you will do in all patients, or you will add anthracycline in certain group of the patients? It's always the carboplatin, paclitaxel, and pembro.
After that, EC or AC has to be given.
Yeah. So it's a 8 cycle over.
8 cycle in total.
In the node positive disease.
Yes.
And in a node negative disease, your regime will be little bit different. So suppose T2N1 disease you are giving NSCT, or T2N1 or N2 disease you are giving NSCT. So your regime will change, or it will be same?
It will remain the same. N1, N2, or even N3, the regime will remain the same. It won't change.
Okay.
Can I just add a couple of other points on the rationale of neoadjuvant chemotherapy in this patient? Number one is a PAT CR is now evidence-based that it is a prognostic indicator, but also if you have a residual disease, the patient could have capecitabine, which has also been shown to improve prognosis. So I think those two are additional benefits of considering neoadjuvant in this setting.
So I think that's the data you want to quote here. So early stage TNBC, if any one of you can summarize that pathway we follow in general for stage 1 and stage 2, where we can do upfront surgery in TNBC, and where we should always think for NSCT for the residents and early career oncologist here. So this is the schema I have put from the ISMO.
I mean, it's very simple that if it is, for us, if it is T1 N0, then surgery up front. If it is T2 or N plus, any T or N plus, then neoadjuvant. That's the guidance in NHS.
So in early breast cancer, if it is a T1, T2, N0, so if it is more than T1 or any node positive should have NSCT. So surgery is very limited to T1, N0 disease in triple negative breast cancer if they are fit for chemotherapy. So coming to this patient again, So any one of you can take the question. Do you feel that we should do the genetic counseling and testing also in this patient, and how it will help in our decision making?
Yes, upfront it should be done.
So we should do genetic counseling. So
Yeah.
how it will help us in managing this patient or future of this patient and the family?
Definitely, if she comes HRR positive, germline positive for BRCA or other HRR genes, and after the definitive surgery, the olaparib or the PARP inhibitor should be.
So you will change the, as per the response adjusted treatment.
Yeah.
Anything you can change in the during chemotherapy pathway if she is coming as a BRCA1 or BRCA2 positive, or still it will be same because we have already added carboplatin here.
Carboplatin, platinum should be given.
Okay. So it will, you will be strict to platinum if it is a BRCA1
Yeah.
positive. But if she is not affording pembro, what will be the chemotherapy backbone? It will be same or different?
Chemotherapy backbone, definitely.
So you are medical oncologist.
Yeah.
Sorry.
Definitely we can go for the four cycles of paclitaxel and carboplatin, followed by anthracycline, or anthracycline can be given earlier also.
So if the patient is not affording pembro, so you will add carboplatin all patient irrespective of genetic mutation, or you will select patient as per the nodal positivity?
No, all patient. If she is BRCA mutant, all patients should merit platinum.
If she is not BRCA mutated,
then we can omit.
Okay. So for quality of life patient, how you discuss fertility planning?
Now the standard is like that most of the patient, all the patient of triple negative breast cancer should get the advantage of platinum agents. We have got a few important trials, randomized phase 3 trials like brightness study, CalGB study, and there's one more GPAR-62 along with nab-paclitaxel study along with the carboplatin. So all those have said that the pathological CR rate with addition of carboplatin is better as compared to when we are not giving carboplatin. So now this has become the standard of care. Now we have got the TMH data as well that has given 8 weekly cycles of paclitaxel along with carboplatin. That also showed better pathological CR. However, in the extended follow-up, it was not showing event-free survival benefit, but the overall survival was better in the recent updated analysis of the same data. So carboplatin or the platinum agent should be added in the neoadjuvant setting of all the triple negative breast cancer.
In a nutshell, if you can give the idea of how we discuss about infertility management during chemotherapy to all the delegates or residents. This patient has completed family, but if the patient has not completed family, do you discuss fertility issue with all patients? If yes, how you discuss? What are the things you discuss with the patient?
So
or
these
it's
are
done by the different team, then surgeon can take this question.
So these are the important aspects which should be discussed with the patient as well as the their partners regarding the fertility issue, because chemotherapy is known to associated with around 15 to 20% of the infertility issues, and it has got long-term implications as well. So we need to discuss, we need to go for the freezing of the ovum or freezing of the sperm as well, sperm preservation. This should be done before we start with the chemotherapy, especially when we are giving anthracyclines and taxanes. These are known to cause the infertility issues in this.
So message what I want to give, that if the patient has not completed family, please discuss fertility issue in the second visit itself when you have seen the biopsy report. Even if you are surgeon, prime them before chemotherapy, and it will help the medical oncologist colleague to discuss the whole fertility issue with them. And it's very important to discuss in young patient what we see if they have not completed the family. So this is the response, almost complete response in this patient with the chemotherapy and the pembro. So what's the surgical plan? So we have discussed already multiple times from the morning. So what we can think for the breast and what we can think for the axillary surgery here.
So since there is a clinical and radiological complete response, so we can plan breast conservation surgery, and for axilla we can go ahead with sentinel lymph node biopsy.
You agree with Dr. Rishi with his plan?
Yeah, I think we should consider same quadrant. I can't say, what was the situation of, you mentioned a lot of macrocalcification, but it seems like a radiological complete response. So either you could consider multiple wide local excision or en bloc if there is calcification in between. So, yeah, I think that would be a reasonable option along with TAD.
So N1 disease, as per our institution protocol, post-necessity is still we are doing LND because we are doing a trial, targeted exit dissection trial. And as per our trial itself, the false negative rate is around 17 to 20%. And as Dr. Manjula presented in the debate itself, we see a little bit higher nodal burden compared to the West. And we need to be careful in de-escalating axillary surgery here. So the final histopathology review was here again to our medical oncologist colleague. It's a complete response. So what will be the...
So it was breast conservation surgery. Right?
Breast conservation surgery. So it's a complete response. So what next? So the patient has received immunotherapy. So you will continue with the immunotherapy or you will stop if there is a complete response. So
9 more cycles of pembrolizumab has to be given every 3 weeks for this patient.
Where you think to avoid pembro if patient is having complete response, or is all patient you will continue pembro?
Well, the trial suggests that all patients will receive, but very early disease like T1C disease, we can avoid the pembrolizumab.
So if it is a node
complication of the complication is there, then we can avoid. Or node negative disease, then we can avoid. So these are the very early breast cancer that are eligible for this trial, this regimen, but very early among them.
So if it is a node negative and T1 disease, and if you are having complete response, probably will not continue with the immunotherapy.
Yes,
so the reverse is that, again I am coming to Dr. Samvi. So pathological complete response we talk about a lot, but what you report in general in histopathology, it's only PCR, or you quantify the response, and do you feel that it's important in our future line of the treatment what we are prescribing?
Sir, we should actually pathological complete response along with residual cancer burden should be mentioned in the report, and for that a proper grossing should be done of the specimen. If the specimen is the post-NSCT case, it should be grossed properly. If the lesion is not evident, any lesion which is appearing suspicious on the grossing specimen should be grossed, the sample should be taken. If you're not able to assess properly, then it's always said that more sections are always better than taking no section or taking less section. Because the more sections we take, there is always a high chance of seeing the tumor there. Even if there is a lot of fibrosis, but if we are seeing a 5% area with a tumor present, we should report it as residual tumor present.
Okay.
And residual tumor present. Even if it is a 5 mm space in the histopathological section, we should report it as residual tumor disease present. We should mention the area, the maximum tumor dimension, both longitudinally as well as perpendicular distance of the tumor area should be mentioned.
Coming to our medical oncologist colleague again, so do you feel that PathCR and RCB1 is almost same in all the trial which we have seen the response adjusted treatment, and do you feel that it's different or we should treat all? So what we see in Indian setting is the locally advanced breast cancer, so N3 disease, and it's a T3 disease, and after chemotherapy we see 1 mm residual disease. So I still feel it's a very good response. It's ultimately very near to the PathCR. So do you think in these group of the patient also we need to escalate towards aggressive therapy? Is always PathCR, or do you think that anything we need to change as per the Indian patient? Because the representation of the locally advanced breast cancer was very less in the response adjusted trial.
It is absolutely debated area, and still it is a gray area to decide whether to continue with escalation of the therapy or to stop the therapy there only. But most of the time, if we are getting any kind of residual disease, we escalate the therapy. In this case, like if the patient is having any residual disease, we should be escalating to the adjuvant capecitabine after the surgery if the residual tumor is.
And if it is BRCA mutation, then probably.
Then not probably we have to give olaparib, and that should be sequenced. We have given capecitabine for 8 cycles, and it should be followed by olaparib for another 1 year.
So
should
do
not
you
be
agree
combined.
upon the same sequence, capacitabine followed by olaparib or
Yeah,
olaparib
yeah.
for 1 year?
No, capacitabine then olaparib. Yeah.
Dr. Rishi, is same in the UK?
Yeah, I think that's the standard, yeah.
So we can combine capacitabine and
Meanwhile,
olaparib
we can
both.
give the pembrolizumab as well along with that.
You want to say something?
It's always, sir, advisable to mention in the histopathology report the area which has DCIS component, because the residual cancer score that we calculate, that includes the DCIS component also. And also it is important to mention what kind of DCIS is there and the percentage of the DCIS component along with its grade. Because generally it is seen that the high grade DCIS components they tend to show a pure response even if we have a very low residual tumor there, residual invasive component along with a high grade DCIS, then they tend to show a poorer response as compared to a low grade DCIS with low tumor area present.
Yeah, point well taken. So you need to be very concise in reporting path-CR, because for defining it path-CR, pathologists work very hard to find a residual disease and give us the score and change our treatment. Sorry, Dr. Amrita, I couldn't reach to you for the radiotherapy question. So what should be the timing of the radiotherapy? So this patient has done surgery. So what's the timeline you follow that you should start the radiotherapy by that timeline, or any effect of on survival by delaying radiotherapy after surgery or after surgery followed by chemotherapy?
As per the literature, the timeline usually that is 4 to 8 weeks, but we prefer starting radiotherapy latest by 4 weeks, because that gives the best local control responses as far we have seen in our institution and previously also. 8 weeks, we generally don't try to reach 8 weeks. If any difficulty, latest by 5, 5.5 or 6 weeks. But the optimum time that we follow at our institution is we start planning in the 3rd week and start radiotherapy by 4th week, if all the healing and post-op complications are okay.
In this patient, what will be the volume and dose fractionation? So this patient was having breast conservation surgery and ALND and complete response.
This patient initially she was a CT2N1 TNBC, a young patient with pathological complete response after NACT, and thereafter she underwent a BCS. So in a young patient, TNBC status, and as far I remember, one of the lesions had a Chi67 of 30 or 40% and the other one had 60%. So definitely radiation has to be given to the whole breast, including the boost to the post-op cavity. Even the lesion is YPN0, but initially since it was N1 and TNBC, so the SCF will be included, but the regional nodal irradiation, that is the axilla, we can omit here.
Okay. So any role of auxiliary radiotherapy in your practice setting? So any patient where you feel that auxiliary radiotherapy is important?
As per the AMAROS trial, as we have seen, it was a comparison between axillary lymph node dissection and axillary radiotherapy. So if the patient has an adequate axillary lymph node dissection, we generally don't prefer axillary radiotherapy. Some cases where we consider are inadequate dissections, high gross volume with ENE positivity, or sentinel lymph node biopsy positivity, but no axillary dissection due to any of the reasons. So these are the few cases where we prefer axillary irradiation, but if adequate dissection has been done, we generally avoid it.
So we have B51 data in this specific setting, T2N1 disease converted to node negative now, and it's a level 1 data, randomized controlled trial to avoid the regional nodal irradiation. So do you think this patient is eligible to avoid SCF radiotherapy?
SCF radiotherapy, as per this data, we can avoid, but in our Indian scenario and as per the patient population that we receive, we generally try to irradiate the SCF if the initial nodal burden was present. Otherwise, like if it was initially N0, just because it is a young patient, high Chi67 and TNBC, I would like to go with the SCF and omit the axillary radiation here.
Yeah. So this patient received everything what you said, adjuvant RT to the left breast and SCF to total dose of hypofractionation. Any fractionation idea, you will use standard fractionation or hypofractionation?
We generally go with the hypofractionation only, 40 gray in 15 fraction. And as mentioned here, the patient has received a SIB, that is simultaneous boost to the cavity of 48 gray. Many a times if the patient is frail, we go with the sequential boost also. But majority cases, we go with hypofractionation.
I think we are running short of time, so these are the evidence with surgical refinement, with a lot of adjuvant and neoadjuvant therapy. So please look upon for the residents. We have de-escalated surgery significantly with the level 1 evidence and real world data evidence. So clinical challenge and barrier to care. So I think we have already discussed. So we are very cost constrained for the immunotherapy. We have testing gaps also, and trial enrollment, especially from the developing country, is very less. So what we are seeing is the data from the West, what we are applying here in all patients. Any role of the ADC in triple negative breast cancer in future to our medical oncologist colleague? That's the last question here. Do you think that ADC will come up in triple negative breast cancer?
Yeah, definitely. Still, we are in the tune of 65%, 60% of PATH CR rate. And we know that PATH CR rate is a surrogate of long-term survival. So definitely the ADC will come in the days to come. And their role is still, there is a place for their role.
So you feel that it will be more important in metastatic setting or early breast cancer setting?
No, obviously their role will be in metastatic setting, but they will find a place in days to come.
Okay. With this, I will conclude, and we are happy to have discussed all the treatment pathway for triple negative breast cancer. You have seen presentation also, and if you, Dr. Rishi, if you want to summarize overall about some message for treating triple negative breast cancer.
I think most of the things have been discussed. I think we should understand that a good receptor status, reliability is crucial. And once you have a diagnosis of early breast cancer, which is triple negative, then a good radiological assessment, good planning if you are giving neoadjuvant chemotherapy. And yeah, I think it is one of the areas where we have seen significant improvement in PATH CR with immunotherapy, and sticking to the current guidelines gives good result. But I can see in future we will have more of the markers being done in early breast cancer, and that's where the future I see.
Thank you very much.
Thank you, Dr. Sanjeet Agarwal, for having such an elaborate and nice discussion on TNBC. Thanks to all the panelists.
It's time for the photo sessions. Kindly come forward. Our chairperson, speaker, and panelist. And for the moment we all have been waiting for, this is the poster presentation time. Out of 30 presentations from different institutes are displayed and evaluated by our STEAMS faculties. Out of 30, 5 best posters have been selected for presentations. Ladies and gentlemen, जोरदार तालियों से स्वागत कीजिए for Dr. Komal Bharti to present her presentations. Huge round of applause, ladies and gentlemen. Now I am inviting judges, Dr. Rishikesh Parmeshwar, Dr. Sanjeet Agarwal, Dr. Ditendra Sarkar, Dr. Navneet Kaur, and Dr. Ashutosh Mishra. Kindly join to the dais.
Good afternoon, everyone. Myself, Dr. Komal Bharti from Department of General Surgery, IGIMS Patna. I am here to present my poster on the topic Beyond the Nodal Count, Why Lymph Node Ratio is the New Gold Standard Post-Neoadjuvant Chemotherapy, under the guidance of Professor Dr. Pawan Kumar Jha, HOD, Professor Dr. Pradeep Jaiswal sir, and Dr. Rinku Kumari. Neoadjuvant chemotherapy is the standard of care for locally advanced breast cancer, often leading to significant downstaging of axillary lymph nodes. However, the traditional post-neoadjuvant lymph node staging can be inconsistent due to chemotherapy-induced fibrosis and low nodal yield, less than 12 nodes during axillary dissection. This is the lymphatic drainage of the breast, which has level 1, level 2, and level 3 lymph nodes. Level 1 lymph nodes are below and lateral to the lateral border of the pectoralis minor muscle. Level 2 lymph nodes are in front of and behind the pectoralis minor muscle, and level 3 lymph nodes are above and medial to the medial border of pectoralis minor. Recurrence rates in various molecular subtypes of breast cancer. We have luminal A, luminal B, HER2 enriched, and triple negative breast cancer. Pathological clearance rate after the neoadjuvant chemotherapy is highest among the luminal A and lowest in triple negative breast cancer. This leads to the concept of lymph node ratio, which shows the highest rate of recurrence in 36.7% in triple negative breast cancer. So even if the nodal yield are less than 12 nodes, we can still get the chances of recurrence through the lymph node ratio. The aim of this study was to evaluate the prognostic significance of LNR compared to traditional post-neoadjuvant end staging in predicting recurrence and disease-free survival in a post-NAC surgical cohort at our tertiary care center. It is a prospective comparative study including 108 locally advanced breast cancer patients who have received the neoadjuvant chemotherapy. The endpoints were the disease-free survival and loco-regional recurrence rate. The follow-up period was 24 months. For statistical analysis, chi-square test of statistical significance was used for both the groups, and it was highly significant, 0.037 in the lymph node ratio group as compared to the conventional YPN staging with the p-value of 0.38, which was non-significant. This is the Kaplan-Meier curve, which shows recurrence-free survival in various groups of LNR. LNR has been further divided into 3 groups: less than 0.02 ratio, 0.2 to 0.65 of ratio, and more than 0.65 of ratio. The more the ratio, the higher the chances of recurrence. With this, I conclude that LNR demonstrates a robust yield-independent predictive marker of recurrence as compared to traditional post-neoadjuvant staging in the post-NAC setting. Clinical impact. This metric should be routinely incorporated into post-surgical pathology assessment to guide the adjuvant systemic therapy and improve overall risk stratification. In a post-NAC sample, if we get less than 12 nodes and we go for conventional post-neoadjuvant staging, then the reports, even if it is lower stage of the lymph node, that is end stage, then even after that we are getting recurrences. So to avoid that limitation, we have the lymph node ratio. If it is more than 0.65, which is the number of nodes which are positive for the metastasis to the total number of lymph nodes retrieved, even if it is less than 12 nodes and the LNR is more than 0.65, then the recommendations are intensified adjuvant therapy and enhanced surveillance. These are my references which have shown the similar result. Thank you.
Can you tell me the evidence, references you have used, the evidence supporting your findings? Just mention 2.
So the references which I have shown the similar results, that LNR ratio if we have less than 12 nodes are very significant, because the nodes are less than 12, then we cannot comment on the recurrence whether it will be there or not, especially with the triple negative breast cancer which have high recurrence rates, and post neoadjuvant chemo they are getting good response, then the number of lymph nodes retrieved are usually less. So this can be incorporated in clinical practice to know whether there will be recurrence, a higher chance of recurrence or not.
Agreed. Just name one study you have used in your reference.
The Create X trial I have used for my study, and that trial have shown the similar results.
So that is for capecitabine. I'm asking your LNR, cutoff point of 0.65.
Sir, the LNR ratio, the low, moderate and high, the 0.02 and 0.65 cutoff, I have taken from all the references. They all have used the similar kind of, they have given results from the similar kind of the ratio. So I have included from that study only. Yes, sir.
Only one basic question. What do you mean by lymph node ratio?
Sir, the lymph node ratio means the number of nodes which were positive for the cancer metastasis as to the total number of lymph nodes which we have in the specimen. So the pathologist use this, and they give the positive nodes out of the total number of nodes, which even if it is less than 12, the 12 lymph nodes are mandatory for a CA breast, but even if it is less than 12, then we can predict the recurrence using the lymph node ratio.
It's 12 or it's 10?
Thank you, sir.
Congratulations, Dr. Kumar Bharti. Next, ladies and gentlemen, put your hands together and please welcome on stage Dr. Narendra to present his presentation. जोरदार तालियों से स्वागत कीजिए.
Good afternoon, everyone. Myself, Dr. Narendra from Savera Cancer Hospital and Multi-Specialty Hospital. So today I am going to present my poster on the topic role of conventional specimen mammography versus frozen section for the intraoperative margin assessment in carcinoma of the breast patient. As we know, breast carcinoma is one of the common cancer encountered in our routine practice, and it was estimated that 1.6 million new cases were diagnosed in 2012 and constituting about 25% of all the cancers. And there is approximately 11.5% increase in the incidence rate, 11.38% increase in the mortality rate between the year 2008 and 2014. So in our Indian scenario, study was done by the ICMR sponsored population-based cancer registry program, which says crude rate and age adjusted risk vary from 12.7 to 34.8 to 13.9 to 41 per 1 lakh population. And the main reason behind the increase in the incidence rate is adoption of the Western life and urbanization of the society. So as we know, the treatment paradigm is changing from radical mastectomy to the breast conserving surgery. So for breast conserving surgery, the most important aspect is the assessment of the intraoperative margin assessment. So there are options available for the margin assessment, which includes imprint cytology, frozen section, intraoperative mammography, which includes two: conventional specimen mammography and intraoperative digital specimen mammography, intraoperative ultrasonography, mass spectrometry, and ICG. Out of these, the most commonly used is frozen sections, and the second one is intraoperative mammography. And our study aim is to assess conventional specimen mammography and frozen section for the assessment of intraoperative margins in the patient of the carcinoma breast undergoing BCS. As I said, frozen section is available mostly in the tier 1 CT, and it is in few centers of the tier 2 CT frozen section is available, because frozen section has very good true positive and negative rate with very high positive predictive value and negative predictive value. And there are very limited trial was done for the specimen mammography, and those shows that sensitivity of mammography is around 53% and the specificity is around 84%. So our aim is use of dual technique, that is intraoperative mammography and frozen section, in the assessment of margin status and comparing it with final histopathological study. And objective is performing conventional specimen mammography and frozen section for the wide local specimen and then comparing the two results with the final histopathology report. This study was conducted in Savera Cancer and Multi-Specialty Hospital, and population where patient who were attending Savera Cancer and Multi-Specialty Hospital. This is a prospective observational study, and I had done this study for 10 months and sample size is 50. And the inclusion criteria includes early and locally advanced carcinoma of breast and the patient who is willing to undergo BCS. And exclusion criteria includes advanced carcinoma with metastasis, patient with fungating mass, recurrent tumor, male breast cancer, and the patient who denied for the consent. So I have used a statistical analysis based on the latest SPS software. So coming to the specimen marking, initially when I started this study, I was taking specimen mammography in a single view, that is AP view. And after in the fourth case, what I noticed that I was not able to confirm the base of the status of the base of the intraoperative margins. So we have decided to do it in two dimension, AP and lateral. In order for that marking, we have used single clip for the superior, double clip for the lateral, and cross clip for the anterior margins, as depicted in the image. So here are few images. These are the two patients. Patient with two lesions were there, one in the upper one and below one in the two-dimension view. Here, patient with a solid and a cystic lesion. This is the patient with a clear-cut margin, as we can see. And this is the patient to post NSCT, and they have found to be a positive margin. So this patient undergo mastectomy. And the fallacy of my study is for a smaller size tumor, which is 1.5 centimeter. We were not able to take the proper image of this based on a specimen mammography. So this kind of image was coming. Coming to results and discussion, so total number of patients who is undergoing upfront surgery is 29, and post NSCT is 21. And laterality, as we say, most commonly breast involved is right breast, followed by the left breast, and the most common quadrant involved is upper quadrant. Most common age affected is 40-50, followed by 50 to 60 years. Youngest age patient is 26, and the eldest one is 76. This is the margin status, where we found one positive patient. The other important part is logistic time.
Can we move to your conclusion fast?
Instead of conclusion, I would say I would like to interpret as a conventional specimen mammography as a fast and practical with higher sensitivity, especially for early breast carcinoma and DCIS, and frozen section analysis most accurate but takes longer time and need specialists to report. Fallacy of the study: a smaller lesion less than 1.5 centimeter doesn't provide a good image, hence not suitable for this study. And future aspect, we can combine both CSR and FS to improve the sensitivity and specificity, and thus reduce the chances of recurrence. And CSR will be a good alternative option for tier 2 and 3 city where there is limited resource for the frozen section. These are my references. Thank you. Thank you. Yeah, ma'am, because this is still ongoing study, ma'am. I'm still continuing.
In the data so far analyzed, what is the sensitivity specificity?
Sensitivity is almost around 91%, ma'am, and specificity is lower side, ma'am. It is around 60%. Exactly, I have not calculated.
Anything you have patients of LABC as well as early breast cancer.
Yes, ma'am.
LABC must have received NSCT also.
Sorry, ma'am.
The LABC patients must have received neoadjuvant systemic before conservation.
Yes, ma'am.
So did you compare the two groups?
Yes, ma'am. That I
So does it matter?
Yes, ma'am. It matters, ma'am. But the problem is with post-NSCT patients, what we observed that for one patient, margin comes as a positive in the post-NSCT, and that assessment is not that good compared to upfront
So
surgery.
it is less sensitive in patients
Yes,
who
ma'am,
have, okay.
for post-NSCT.
So, what's the adequate margin definition?
No ink on tumor.
It's same for both invasive or DCIS?
No, sir. For DCIS, it's minimum 3 mm is required. 3 mm or 2 mm? 2 mm.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Dharmendra, for your presentation. Next, I may invite on the stage Dr. Namita Mittal to present her presentation.
A very good afternoon to everyone. Today I am going to present a presentation on the topic feasibility of axillary lymph node clipping using low-cost LIGA clips and tattoo dye prior to neoadjuvant chemotherapy. Breast cancer is a highly prevalent malignant tumor surpassing lung cancer as the most commonly diagnosed cancer worldwide. With approximately 2.3 million new cases reported annually, it remains one of the leading malignancies affecting women. Early surgical intervention plays a critical role in preventing the spread or metastasis of cancer cells, thereby improving the patient's survival outcomes. Breast cancer spreads through the lymphatic system, with the first site of dissemination being the immediate draining lymph nodes, the sentinel lymph nodes, then the second and third tier nodes and beyond. This predictable method of spread allows for the use of lymph nodes in cancer staging and prognosis, with their involvement often being the most significant prognostic factor. Accurate axillary staging is hence critical in breast cancer. However, after neoadjuvant chemotherapy, lymph nodes often shrink or disappear, making localization of initially positive nodes challenging. This creates a need for reliable yet cost-effective localization technique, especially in resource-limited settings. Rationale of the study: conventional localization methods are costly and resource intensive. Low-cost alternatives are essential in low and middle income countries. LIGA clips along with the tattoo dye offers a simple, reproducible solution. The AIIMS and objectives: the aim is to evaluate the feasibility of low-cost LIGA clip along with tattoo dye marking and to assess the targeted node retrieval rate, sentinel lymph node identification rate, and pathological concordance. The study was conducted in the Department of General Surgery after obtaining ethical clearance from the Institute Ethical Committee IGIMS. Written informed consent was obtained from all the patients before enrolling them for the study. It was a study of 1 year duration with a sample size of 22 biopsy-proven node-positive patients. The first biopsy-proven node-positive breast cancer patients, 22 patients were selected. Then pre-NACT intervention, that is LIGA clip placement along with tattoo dye injection was done, followed by neoadjuvant chemotherapy. In the then there was the post-NACT surgical phase, during which targeted axillary dissection was done, that is removal of the clipped lymph nodes along with the sentinel lymph node biopsy using fluorescein sodium and methylene blue dye. Then followed by complete axillary lymph node dissection, which is the gold standard. Then for the outcome assessment, we looked at the targeted node retrieval rate, sentinel lymph node identification rate, and the pathological concordance, followed by the discordance rate. Key results: targeted node retrieval was 100%, sentinel lymph node identification was 100%, concordance with axillary lymph node dissection was 95.5% with a discordance of 4.5%. Targeted clipped lymph nodes were identified in 100% of the patients. 1 clipped node retrieved in 21 patients and 2 clipped nodes retrieved in 1 patient. Sentinel lymph nodes identified in 100% of the patients. 1 lymph node in 16 patients and 2 lymph nodes in 6 patients. Axillary pathological outcomes: 21 patients had targeted axillary lymph node dissection negative with only 1 ALND positive, that is a discordance of 4.5%. High identification and retrieval rates validate the technique reliability. Low discordance supports oncological safety and comparable to high-cost localization techniques. Concluding, low-cost LIGA clip and tattoo dye is a feasible, safe, and effective method. It has excellent identification and retrieval rates, and it is highly suitable for resource-limited settings. At last, I would like to say that it is a simple innovation which can deliver high accuracy, cost-effective alternative to conventional methods, and it has the potential to reduce unnecessary axillary lymph node dissection. In the future, we can look forward to large multicentric trials, standardization of the protocol, and integration into routine breast cancer management. These are the references. Thank you. Thank
Hello.
you, sir.
That's a very good study. Did you say that you used both clip as well as tattooing of?
Yes, sir.
So what was the concordance of tattooing? And you mentioned about your clip retrieval. What was the concordance of your retrieval with just tattooing? All those nodes, I believe, also had tattooing present?
Sir, concordance between clipping and tattooing. Sir, it is 100% because we use carbon, the black carbon stain for tattooing, which lasts for several months as compared to the blue dyes like methylene blue, which wash away quicker.
Okay. So may I conclude that just tattooing will be another option?
No, sir. Always using two methods is superior as compared to using a single method. So that is why we are doing clipping and tattooing, and then at the time of surgery, we are also doing sentinel lymph node biopsy along with it to improve the detection rates.
That's okay, but that's not your study says. Your study is quite,
sir,
small.
If we are doing a targeted axillary dissection, what it says that after NACT there will be tumor shrinkage which can be concentric or non-concentric. So in order to not miss those lymph nodes which have been shrunk, we are doing the clipping. And along with that, at the time of surgery, we are pairing it with sentinel lymph node identification so that we can retrieve as much lymph nodes as possible, and then...
That's okay. That's all right. That's okay.
Did you face any problem of
thank you, sir.
Did you face any problem of the staining of the area while doing your sentinel node? Because the injection of tattoo may not exactly be in the node. It may be around the tissue, and that causes kind of a identification issue with methylene blue and tattooed area.
Ma'am, since we are using only a small amount of injection, it does not spread that much.
What is the volume? I wish you had specified the methodology. How much is it being injected and exactly where?
Ma'am, it is injected peritumorally, 0.5 ml in all the quadrants.
The carbon tattoo?
Yes. Ma'am, carbon tattoo is not. Carbon tattoo, when we are doing USG guided FNAC, at that time only, we clip the lymph nodes under USG guidance, and under USG guidance only, we inject the carbon dye. So it
How
is
much?
0.5 ml.
0.5 ml?
Yes, ma'am.
Within the node?
Yes, ma'am.
Okay.
Can I ask a single question? Did you feel that carbon tattooing was more, I mean, you are taking out more nodes because of carbon tattooing versus clipping only? Because it requires a specialized training of the radiologist to actually carbon tattoo the surface of the metastatic node. In our experience, we have faced this problem because the radiologists were not quite trained. Most of the time there was more spillage. We were taking out more nodes because of carbon tattooing rather than using single technique like clipping.
Sir, since this consisted of only 22 patients, so at present we did not face this issue, but if we increase the sample size or conduct large multicentric studies, then maybe we would be able to encounter this problem and then go for the solutions. Thank you.
Thank you, Dr. Namita, for your presentation. For the next poster presentation, I may invite on the stage Dr. Shwet Shikha.
Good afternoon, everyone. This is Dr. Shwet Shikha, presenting my poster on versatility of LICAF flap in oncoplastic breast surgery and its impact on early aesthetic outcome, symmetrization, and patient satisfaction. The place of my study is Savera Cancer Hospital. Introduction is, breast cancer is the most common cancer among worldwide, and BCS has emerged as a standard of care for early breast cancer. It is associated with better cosmetic outcome and improved quality of life compared to mastectomy, as it allows for greater preservation of breast appearance. The integration of oncoplastic breast surgery enhances the traditional BCS by incorporating reconstructive technique and enhances the aesthetic outcome. Oncoplastic breast surgery improves the cosmetic outcome and reinforces patient confidence and satisfaction. The aims and objective is to evaluate the versatility of LICA flap in immediate breast reconstruction following BCS after 3 months of surgery. And objective is to assess the aesthetic outcome using a POSAS scale, Harvard scale, and symmetrization and contour using clinical and photography, and patient satisfaction using breast Q and Likert scale. Materials and method. This is a prospective study which started in July 2025 to January 2026 with total 20 patients of BCS undergoing LICA reconstruction. And the study population is in the Department of Surgical Oncology in Savera Cancer Hospital. The inclusion criteria is patient with pathologically proven breast cancer who went BCS reconstruction with immediate LICA flap, and tumor located in lateral, outer or central quadrant of the breast. The exclusion criteria is history of previous breast cancer therapy, inner quadrant, multifocal disease, pregnant or lactating woman. Surgical technique. The location of primary tumor was determined and marked. A handheld Doppler probe used to accurately localize and mark the perforated branches of the lateral intercostal artery. The flap was then designed by drawing an initial semilunar line in the lateral mammary sulcus, which represent the medial margin, and then a second semilunar line, which was drawn inferior and lateral to first line at a distance almost same to the width of the lump. BCS done with frozen section proven negative margin all around. SLNB and or ALND done through lateral edge of the flap. Flap harvested from the lateral lesion and with optimized arc of rotation and optimal contour restoration. Flap was transposed into the defect and meticulously sutured to achieve the symmetry with contralateral breast. And this is the whatever the surgical technique, the technique that I use. In the sitting position I have marked, and in standing position as well. The location of the tumor is identified with the handle Doppler. I identify the perforators, then mark the flap size, and then with the tumor excision and with arc of rotation, I have transposed the flap into the defect. And this is the 3-month outcome of the patient of the LICA flap reconstruction. Discussion: the LICA flap has emerged as a versatile flap and reliable in oncoplastic breast surgery with low mean POSAS observer score indicating a good scar quality, high proportion of excellent to good result on Harvard scale, and high patient satisfaction score. Limitation, sorry sir, instead of, yes sir, sorry. Total 20 patients were taken which underwent breast reconstruction using LICA flap. 80% of the patients saw good result, good to excellent cosmetic outcome on Harvard scale in breast symmetry, shape and contour. 60% of the patient were satisfied and 20% were very satisfied in terms of emotional and physical well-being, and satisfaction with scar as good to very good in 60%. 20% of the patient account for seroma formation and none of them saw flap necrosis. This is the POSAS scale which include patient score and the observer score, that is the clinician score, which the observer score and the patient score is written here. And the Harvard scale, the grading was done in the 4 segment, the excellent grading, good and fair and poor. The excellent grading include the patient, the operated side look similar, identical to the contralateral side. Good is almost similar, and the fair is a little inferior, and the poor is dimorph. And on Likert scale, which is the patient satisfaction scale, the 4 out of 20 patients showed 20% of the very satisfied, and 12 out of 20 patients shows 60% in the cases they satisfied. And the breast Q on the scale, patient satisfactory scale were depicted here, which include the overall symmetry, the shape, contour, quality of life, body image, emotional well-being and physical well-being. And the conclusion is in immediate breast reconstruction, LICA flap is favorable in aesthetic, surgical and psychological outcome. High level of patient satisfaction, safe and effective solution for patient requiring partial breast reconstruction, and minimal donor site morbidity. Thank you. Thank you, sir.
When you have assessed each questionnaire, so after surgery, before surgery, what was the timeline for assessment?
So before the surgery, first, and then sir, after surgery, after 3 months. I have made clear about all the questionnaire that will be asked after 3 months of the surgery. So I have made all the questionnaire. I have made one paper of the questionnaire that I discuss with the patient before the surgery and tell them tell them to give opinion after 3 months and will assess.
Why 3 months? Any specific reason?
No, sir. It's a ongoing study. I'm doing it at 3 months, 6 months, and then at 1 year, and then we'll evaluate finally.
Why 1 year? Any specific thing you want to look upon after 1 year?
Yes, sir. The cosmetic outcome. By that time, all the fibrosis and that heal by that time.
Why this fibrosis will happen? Any specific thing we are adding?
The morbid. No, I mean.
So why you are assessing at 3 months, 6 months, or 1 year? There is a valid reason for that.
Yes, sir.
So we can do up just after surgery and say that it's a very valid outcome. So why this 1 year timeline is important?
Initially, patient were not emotionally emotionally and psychologically so.
So you are.
Yes, sir, exactly. With a neoadjuvant. Yes, sir. Post BCAs, the RT is mandatory, so it may change the outcome in immediate post-operative period. So that's why this may be one of the reasons.
Okay. Thank you.
Thank you, sir.
Thank you, Dr. Shweta, for your presentations. For the last poster presentation, I may invite Dr. Juhi Prabha to present her presentations. जोरदार तालियों से स्वागत कीजिए.
Good afternoon, everyone present here. Today I'll be presenting my poster on the topic "When Molecule Meets the Mammography: A New Era in Early Breast Cancer Detection." My guide is Professor Dr. Pawan Kumar Jha sir, Professor Dr. Pradeep Jaiswal sir, and Dr. Rinku ma'am. Coming to the introduction part, as we all know, breast cancer is the most common malignancy among women worldwide and a leading cause of cancer-related mortality. Conventional screening methods, which we all have, is 2D mammography, which have several limitations, like there is reduced sensitivity in dense breast tissue, leading to higher chances of false negative results, and detection occurs only after a structural change develops. Whereas 3D mammography, that is digital breast tomosynthesis, is an advanced imaging modality that improves lesion detection even in the dense breast, reduces tissue overlap, and decreases recall rates compared to the 2D mammography. In conjugation with the imaging, circulating tumor DNA has emerged as a promising minimally invasive biomarker that detects the tumor-derived DNA in blood, enables identification of cancer at a preclinical stage, provides a lead time advantage before radiological detection, and hence the combination of ctDNA and 3D mammography may enhance the early diagnosis, facilitate timely intervention, and ultimately improve the patient's prognosis. The aim of my study is to evaluate and compare the effectiveness of the circulating tumor DNA and 3D mammography for the early detection of the breast carcinoma and to assess their combined diagnostic utility in high-risk women. The objective of my study was to determine and compare the sensitivity, specificity, positive predictive value, negative predictive value of ctDNA, 3D mammography, and also to assess the ability of ctDNA to detect breast cancer at a preclinical stage and compare it with the imaging finding. Also to evaluate the association between the ctDNA positivity and confirmed malignancy, and to assess the diagnostic value of combining ctDNA and 3D mammography in predicting breast cancer. Coming to the methodology, it is a prospective observational study having duration of 2 years, and the study population was 140 female having age more than 35 years and having positive family history of breast cancer. In the study procedure, there was 2 procedures. First was the collection of peripheral blood for the extraction of circulating tumor DNA, and analysis was done using next generation sequencing. Second was the radiological assessment, that was 3D mammography, and reporting was based on the BRIG classification. Third was histopathological study. All the participants whose 3D mammography suggested BI-RADS category 4A, 4B, 4C underwent ultrasound guided true cut biopsy when possible, including the follow-up period. And in follow-up, the patient followed up as per the BI-RADS category, and those positive for ctDNA followed every 6 months irrespective of BI-RADS category, and then correlated with clinical finding and histopathology. Results and discussion. 3D mammography demonstrated excellent sensitivity with 100%, making it highly reliable for detecting breast carcinoma and minimizing missed diagnosis. Whereas circulating tumor DNA had sensitivity of 90.9% and strong association with malignancy. Out of 44 positive patients, there were 45.5% of the patient who came out to be early breast cancer patient, and remaining ctDNA negative patient, there was only 2.1% of the patient who turned out to be early breast cancer patient, highlighting its role as an early molecular biomarker. Both modalities exhibited high negative predictive value of more than 97%, indicating strong reliability in excluding the disease. The combined use of ctDNA and 3D mammography significantly improved diagnostic accuracy, with 81.8% of cases confirmed malignant when both tests were positive. A significant association was found between both ctDNA status and mammography finding, and with histopathological diagnosis having p-value of less than 0.01 for both modalities. This is the graph showing the comparison between diagnostic performance of ctDNA versus 3D mammography. Conclusion. Coming to the conclusion of my study was a multimodal approach integrating molecular ctDNA and imaging, that is 3D mammography technique, provides a more effective strategy for early detection and risk stratification of the breast cancer. Thank you.
My 2 questions. How did you manage the funds for the study?
Ma'am, actually for the first few cases, like 30-40 cases, we had to outsource the sample because it was expensive. I had already applied for extramural funds, and I have received ICMR fund and also from Bihar government. And
total funding for the
total funding was around 1,85,000, combining both, and remaining 1,25,000 or 1,50,000 that I have given for this study.
Hello. Can I have few questions, please?
Yes, sir.
What do you see the impact of this study?
So the positive, I will first talk about the positive impact. The positive impact was that in 22 patients, among the 140 patients, there were 22 patients who were diagnosed as early breast cancer. So in these 22 patients, we straight away went for the BCS, followed by radiotherapy and whatever regimen is going on. So we have improved the life
Now suppose if you have excluded ctDNA estimation,
yes,
what difference it would have made to the study?
Pardon, sir?
If you had done only mammogram instead of adding the ctDNA, what difference it would have made to your study?
Sir, 3D mammography is already an established thing for the screening program, and in the in my study there were 40.
So you mean to say that you want to replace?
I want to actually get a lead time. Since ctDNA is the circulating tumor DNA which is available in the peripheral blood.
Can I ask you a simple question?
Yes,
what
sir.
do you understand by a passenger mutation, and what do you understand by a driver mutation?
Passenger mutation and driver mutation.
Driver mutation.
So driver mutation are those who initiate the carcinogenesis, and passenger are those who sums up the, like in CA colon, there are multiple.
Thank you very much. Thank you very much.
Thank you, Dr. Juhi, for your presentations. Now I am inviting all judges on the stage to announce the 3 best poster presentation award, and that is iPhone Award. Ladies and gentlemen, please welcome our judges, Dr. Rishikesh Parmeshwar sir, Dr. Sanjeet Agarwal sir, Dr. Diptendra Sarkar sir, Dr. Navneet Kaur ma'am, and Dr. Ashutosh Mishra.
So I think it will take time for calculation. So the 5 have marked differently, so it will take time.
Okay, all right, all right. We'll wait as they are taking decision. I know you all are excited to know who is winner. Finally, the prestigious Poster Award 2026 is presented to winner इस बार तालियां थोड़ी दमदार होनी चाहिए क्योंकि बहुत खूबसूरत तरीके से पेश किया है हमारे सारे डॉक्टर्स ने प्रेजेंटेशंस. So over to you, judges.
Well, you all did very well. You should be proud of yourself, but there's only 3 winners, you know, 1 winner and then 2 runners-up. That's how the award is, I believe, right? Organizers, there are 3 prizes to be given?
3 prizes and 2, all 5.
Yeah, all 5 will get some. Okay. I think just advice to all of you, you all had a very good presentation. Some of you missed out on marks because you spent too much of time talking about the background rather than getting on to the result. So do bear in that mind because your score could have been completely different if you had gone on to your findings earlier and then spent more time discussing. So the winner is Namita first. And second prize goes to Komal. And third prize goes to Juhi. And I think the other 2 also need to come to collect. Yeah. Please come forward, all the participants, and get your consolation prizes as well. Thank you.
Others
please.
Can come. So the 4th and 5th.
Congratulations to all the winners. A thunderous applause for all participants, ladies and gentlemen. As we draw to close, we would like to extend our sincere gratitude to everyone who made this day possible. And for vote of thanks, I would like to invite on this stage Dr. Rahul Chaudhary, sir, co-chairman.
At the outset, I would like to thank the organizing committee, and I'm deeply privileged to present the vote of thanks on behalf of Bihar Breast Group and Savera Cancer Hospital to all the participants who have come here and spent their Saturday and Sunday with us, to all the speakers who have shared their knowledge and expertise, the faculty who have taken the pains to come down to Patna for the conference. And I would like to thank all those people who have worked both in front and behind the scenes, all the paramedics, the people who've organized the conference, our industry partners, for making this CME come workshop a grand success. We hope for more such future interactions, and I hope whoever has come here has gained something out of it, and will take back fond memories of Patna home. So Dr. P.K. Jha, Sir Jaiswal, sir, please come forward for the photograph, please. We are all hungry. The lunch will be served on the first floor in the Utsav hall. So after the photograph, please join us for lunch.
So now here we come to the end of the session, of all the sessions rather, and the conference is yet to be signed off. So before we sign off, let's call it a valedictory function. May I request everybody to come over the stage for a photograph? May I request all the faculty members to come over the stage for photograph? Akash, please request everybody to, whosoever can join in, for a proper photograph before we depart. And let me thank all of you on behalf of ABSI SKILLCON entire team, which has been relentlessly working day and night. You have worked very hard to make it a big success, and fortunately everything stood in place, and everything was up to mark. And still there were good posters, and we have awarded iPhone 18 to the first, and sorry, 17 it's, no? 17, 18 first prize. iPhone 17 is the first, second is 16, and third is also 16. So congratulations to all the winners. This will definitely keep you updated, and it will act as a catalyst for you to next time present an even better poster, and whosoever has secured second, third, fourth, fifth will secure first in the next one. So with this, I thank everybody. May I request everybody to come over the stage for a photograph. And with this, I thank all the institutions, AIIMS Patna, IGIMS, PMCH, NMCH, Sasaram Medical College, Gaya Medical College, Muzaffarpur Medical College, and all those from all over in Bihar who have participated in this and made this a grand success. And last but not the least, I must thank our
Savera Cancer Hospital, the people, our staff members who have worked day and night to make it a big success, with special names to mention: Rahul, Rajkumar ji, Roshan, all of you have worked very hard. Pawan ji, आप लोग भी आ जाइए. इसके बाद रवि, भावना, सबको please come over. आप लोग का भी हम लोग चाहेंगे कि photograph हो जाए. Thank you very much, once and all, for everybody. And here we come to a session to conclude. And thank you again, everybody. Let's join for lunch. And before we end, there is a small memento for everybody. And anybody who would like to speak, Dr. Rishi wants. Yeah. Before we depart, Dr. Rishi has offered for a UK fellowship in case you qualify and you want it. And for that, you have to strive hard. You can apply for, you will get the email and probably through which you have to apply. But what we have decided, the best posters in our scenario, whosoever gets, will be getting a chance to apply. And in future also, we'll be keeping in that way. The best 1 or 2 or 3, whichever is in the sequence, will be getting an opportunity. You can apply and try your luck. And Dr. Rishi has promised to support there, both financially and physically. He'll be there because he'll be training you in that sense, and it will be a big, I will say, academic boost, as well as he'll be supporting financially as well. So with these words, let us sign off. Thank you, Dr. Deeptendra Rishi sir, and all the members, all the faculty members from all over India and abroad who have joined us. Thank you once again.
I, Jennifer, would like to bid you all farewell. Thank you, organizing committee, for giving opportunity. Special thanks to Dr. VP Singh sir. Thank you very much. Stay happy. See you soon.
I'll be failing in my duty if I don't recognize the industry partner who have been supporting us both financially and physically. They have worked also day and night. Thank you for participation. And last but not the least, the media partners who have covered our session well. Thank you again once and all. May I request organizing team Savera to come over the stage? Team Savera, please come over the stage. Team Savera, ऊपर आइए. सब कोई ऊपर आइए. Including Jennifer, you also are part of Team Savera now. You also come over. सब कोई ऊपर आ जाए. आइए, हाँ, आइए. आइए, please. Anita ma'am, Team Savera is joining it at the stage. एक ग्रुप फोटोग्राफ हो जाए. I must thank our anchor Jennifer